You can take your breakfast plates to the chairs. Yeah, I would like to start. So, good morning, friends. Welcome to Nagpur. Welcome to Hotel Center Point. Outside temperature is 27 degrees Celsius, but inside it's cool at 20 for all of you. It's the month of March. March is the spring month, and spring stands for romance. And we have chosen a very tough organ for romance this morning. So it's romance with Pancreas. But to make the romance easy, we have got romantic giants in the respective fields. Dr. Amit Maydeo in therapeutic GI endoscopy, Dr. Sadiq Sikora in GI surgery, and Dr. Rupjyoti Talukdar, a pancreatologist and a basic researcher in the field of pancreas. So I welcome all of you once again, and it's a delight to have you here on this lovely Sunday morning. I'll just give you a brief outline of the program that is going to follow. We have got 3 modules. One is acute pancreatitis, second module is chronic pancreatitis, and third one is pancreatic malignancy. Very briefly, after the first module, so around 11 o'clock, there will be a short 10 minutes break, mainly for lighting the traditional samai and a very, very small program of inauguration. So, this program is jointly hosted by Digestive Diseases Society Nagpur and Vidarbha Surgeons Association. We are lucky to have the blessings of these 2 societies, and from Digestive Disease Society we have Dr. Shrikant Mukhewar, the founder, president, the chief coach, the captain, and also the opening batsman today. And Dr. Vaibhav Banait is current secretary. I think he'll be arriving any minute. Abhiram Paraspe was the joint co-founder along with Dr. Mukhewar. He was the founder secretary of Digestive Disease Society. From Vidarbha Surgeons Association, we have Dr. Girish Jatkar, who is the president, and Dr. Nirmal Patle, who is the secretary. So they would be also joining us very quickly. The first talk is by Dr. Shrikant Mukhewar on etiological evolution of acute pancreatitis. May I call upon the chairpersons, Dr. Rajesh Singhvi, Dr. Abhiram Paranspe, and Dr. Dilip Gupta, to take the chairperson seat and begin the proceedings right away. Thank you very much. There is a suggestion. The front sofas are for all faculty and senior members. So if the chairs are a bit uncomfortable, you can take and occupy the front seats and on the sofa. Thank you.
Sir, you can start
Yeah.
straight away.
Good morning, friends. At the outset, let me express my sincere thanks to Prashant Yogesh, Vidarbha Surgical Association and Digestive Disease Society for giving me this opportunity. The topic I am given is acute pancreatitis. What are the causes and how do you proceed to evaluate when the patient comes to you? Now, by definition, when you have acute inflammation of the pancreas and peripancreatic tissue, it is defined as acute pancreatitis. And by Atlanta, you have to have 2 out of 3 criteria satisfied to get a diagnosis. The abdominal pain should be like a characteristic of pancreatic, severe pain, maybe upper abdomen, episodic pain, back pain, and nocturnal associated with vomiting. The lipase may be 3 times normal, and there is imaging evidence of acute pancreatitis either by CT, MR, or ultrasound. In clinical practice, we have seen that the patients have dyspeptic symptoms and the lipase is done, it is elevated, and they are referred as acute pancreatitis and send it to us. This forms, acute pancreatitis forms one of the important causes of hospitalization, and the US, it is believed that $20 billion are spent annually on acute pancreatitis hospitalization and treatment. Now, the most common etiology of acute pancreatitis is gallstones, which is seen in about 40 to 70% of patients with acute pancreatitis. The mechanisms are predominantly two: the obstruction to the ampulla with the reflux of bile, or obstruction to the pampilla leading to edema and transient obstruction. Many of the patients, they will ask you that I have small stones, so they are not dangerous. In fact, I would say that the small stones are more dangerous because they can pass through the cystic duct and get hold at the ampulla, leading to acute episode. And it has been clearly shown that cholecystectomy and clearing of CBD by ERCP reduces the risk of pancreatitis. Alcohol, around 20 to 40% of acute pancreatitis is secondary to alcohol. Why some develop while others not is a question. Possibly genetic and environmental factors are responsible. I remember that the patients who have had alcoholic pancreatitis, their samples were taken by Dr. Whitcomb in Pittsburgh, who had a strong research for genetics, and many of them, they had genes associated with pancreatitis. Oversensitization of acinine to CCK leading to increased enzyme synthesis by acinine, activation of trypsinogen to trypsin. So possibly those of alcoholic who have developed pancreatitis possibly have a genetic basis that explains why some person drinking heavy alcohol doesn't get, others he gets. And majority of the times it is observed that the duration of alcohol consumption is 5 years or more, but sometimes with binge drinking, and in our clinical practice we have seen that you get patients who develop pancreatitis otherwise. Now the initial concept was alcohol causes chronic pancreatitis. Now the concept is, after prolonged follow-up of these patients, it has been observed that the follow-up of 10 years, 12 years, that they can present only as acute pancreatitis and no chronic changes have been observed. Smoking increases the risk of acute pancreatitis, chronic pancreatitis, acute on chronic pancreatitis, and it has been shown that the more cigarette smoking, the risk is more. Mechanism is not known, but possibly related to bicarbonate secretions. Hypertriglyceridemia forms around 10% of pancreatitis is hypertriglyceridemic pancreatitis. Majority of these patients would have levels of more than 1000, but we have seen also with the lower levels of 500. The causes can be primary genetic causes for hypertriglyceridemia, metabolic syndrome, hypothyroidism, medications like tamoxifen, beta blockers. Post-ERCP pancreatitis, sometimes it can be very fatal, 3 to 5% of routine and 25% with sphincterophory manometry. The young patient, especially females, non-dilated duct, and when you do the pancreatitis for a borderline, ERCP for a borderline cause, these are the patients who are more dangerous and can have. The procedural factors are prolonged procedure, pre-cut, pancreatic duct repeated cannulation. This leads to edema, obstruction, and zymogen activation inflammation. So there is a role of all these epinephrines, pancreatic stents, and NSAIDs. Genetic, I think Dr. Rupjyoti is there who have a basic research on this, and possibly he should be giving us more insight into this topic. But presentation can be as a recurrent pancreatitis and childhood pancreatitis, progresses to chronic pancreatitis. These are the various genes which are available. Majority of idiopathic pancreatitis possibly have a genetic base. Now, in clinical practice, any patient who is young patient and coming with repeated episodes of pancreatitis and you're not finding any other cause, probably you must think of genetics as the etiology, and the testings have been possible in India, especially in AIG. I think most often what is forgotten in the history is history of medications, and 5% or less have medications as a cause of pancreatitis. Majority of the times, if you identify and stop the drug, probably prognosis is good. We have seen patients of 6-MP, 5-USA causing pancreatitis, diuretics, sulfonamides, valproate, tetracyclines. The highlighted in the red are the patients which we have encountered in our practice: azathioprine, estrogens, steroids, and diuretics. Anti-HIV drugs have also been one of the common in clinical practice to cause pancreatitis. A blunt trauma of abdomen, blunt or penetrating, commonest is cycle handle in the younger age group, can lead to mild contusion to severe crush injury and may cause a ductal disruption and ascites. Rare causes are biliary sludge and microlith. Sludge with small stones, microlith means less than 3 millimeters. They have a cholesterol and calcium crystals. So, the way to diagnose pancreatitis is whenever any patient with acute pancreatitis has a liver enzyme elevation, one has to strongly suspect that this patient, even if he may not have gallstones seen on ultrasound, you have to suspect. By and large, it is observed that the bilirubin and the alkaline phosphatase are normal. So, strong possibility is seen by liver enzyme elevation. In our country, especially in Kashmir, there were many cases of ascariasis reported causing pancreatitis, periampullary diverticulum and tumor, sometimes celiac, a rare cause, we haven't seen in our practice. Autoimmune pancreatitis again is a rare entity. Presentation, so you have a patient with enlarged gland, painless jaundice, sausage-shaped pancreas. Possibly you are dealing with autoimmune pancreatitis. You will have to have known this entity in mind to diagnose it. IgG4 is elevated. Hypercalcemia, we have encountered many patients with hyperparathyroidism, at least more than 20 to 25 in our practice. Calcium activates trypsinogen leading to pancreatitis. The cause can be hyperparathyroidism, iatrogenic hypercalcemia or hypervitaminosis D. Infections, these are not very common causes of pancreatitis, but one has to keep in mind like mumps, varicella, herpes, HIV can also cause. Ischemic pancreatitis, this is one of our patients who had celiac artery stenosis which led to presentation as pancreatitis. Of course, it's an uncommon cause, but whenever you have shock or hypotension, the pancreatic ischemia occurs. So any patient with multi-organ failure, pancreatitis can be a manifestation. Anatomical abnormalities, especially in the younger age group, are the choledochal cyst and anomalous pancreatobiliary junction, long common channel responsible. This is the recent one of our patients who, as you can see here, you have pointer? There is So the PD opens in the bile duct there. So this is anomalous, a very recent ERCP. Now 30% of the patients, even if you do EUS, MRCP, manometry and bile crystal analysis, we don't find the cause and they are truly idiopathic. Probably I think they could be having a genetic base, and many other times we have a patient, you ask history of alcohol, you ask history of gallstones, the LFTs are normal, there is no increased calcium, no increased triglycerides. And when you rule out all the causes and get them for a EUS, you will see either a microlith or a divisum or these are the things. So, evaluation wise, find out history of gallstones, alcohol, medications, trauma, infection, family history of pancreatitis, pancreatic cancer and hypertriglyceridemia. You have to find out about the simple clinical examination, like patient comes with tachycardia or high respiration rate, hypotension. These are the patients who would directly go on for hospitalization, and these are the investigations which you do. So the first thing when the patient comes to you is to decide the severity of pancreatitis. So monitor for SIRS and organ failure at hospitalization and for 48 hours. The three criteria are taken to decide what is the severity. One is organ failure, whether you have to measure oxygen to find out whether it is a respiratory failure, creatinine to find out renal failure, hypotension and dehydration. So one is organ failure, local complications like pancreatic collection, splenic vein thrombosis, systemic complication like, as I said, hypoxia, renal failure, hypotension. Mild pancreatitis is a one with 1% risk to the life. Patient do not have local or systemic complication or no organ failure. Moderate sterile pancreatic necrosis, transient organ failure, recovers within 48 hours. There is a third entity which has been added now, that is moderately severe, prolonged specialized care and the organ failure persists for more than 48 hours. And severe, when you have multiple organ failure, having a mortality of 20 to 40, and they have also added one more entity, that is a critical pancreatitis, when the patient has a very stormy presentation. For deciding this, there are various indices, but follow short of time, I am going to stick to what is the best index which we use in practice. The Bishop index, blood urea nitrogen, impaired mental status, SIRS, age more than 60, pleural effusion, has been validated in more than 18,000 patients. Bishop score of 3 or more suggests that the patient has more chances of severe pancreatitis. Organ failure can be, odds ratio is 7.4, persistent organ failure odds ratio is 12.7, and pancreatic necrosis. The worst combination is you have a pancreatic necrosis and organ failure. This is the CT score. I won't go into the details that's available. I would conclude that define pancreatitis as per Atlanta, try to find etiology of pancreatitis to treat. I'll just give an example. One of the most prominent business person in Nagpur city had recurrent bouts of pancreatitis. He had gone all over the country, and I told him that there would be some cause. So he went to Amit. He diagnosed him as a small stone in the ampulla, which was responsible for his 6 episodes of pancreatitis. ERCP was done, stone was removed, and he's better. I have a follow-up of 6 years. Finding etiology prevents recurrence, stratify into mild, moderate, severe. Bishop score and CT severity index are the best score to decide mortality. Thank you.
Thank you, sir. One question I would like to ask. During COVID pandemic, did you find any extra incidents of acute pancreatitis?
Basically, during COVID, in fact, if you remember, in our clinical meeting, we had presented around 15 patients of pancreatitis, which we encountered during COVID era. And in fact, out of 15 patients which we have, 3 to 4 died because of the severe acute pancreatitis. It was said that the COVID virus per se can directly act on pancreas, leading to pancreatitis. And there are other mechanisms like coagulopathy, increase, and
Immune response.
Immunological response.
And does etiology predict severity also?
By and large, not. Severity, the factors are different. We don't know really why some patients develop mild pancreatitis and why some patients would develop severe pancreatitis.
Just one thing. We had patients of dengue recently. What we found was the incidence of pancreatitis increased in dengue pancreatitis thing.
Where?
Dengue.
Dengue,
We have seen that there were so many patients, and even we have published a paper about that.
Yeah.
But etiology could not be found. In dengue, actually, what is the mechanism for that? So probably you
See, all these infections, they can lead to some amount of dehydration, hypovolemia, leading to pancreatic ischemia, like patients with severe infections like dengue shock syndrome. You will have pancreatitis as a manifestation. In any illness which is multi-organ involvement, hypotension, you encountered many cases of pancreatitis.
I don't think we have further time for any more questions. Thank you very much, Dr. Mukhewar.
Thank you.
For your
Thank
very
you for
nice
this
talk.
opportunity.
Thank you.
Yeah, Tommy sir, he wanted to ask a question. Tommy sir, yeah, please.
In fact, the goal of treatment of these patients has to be reducing triglycerides. Many a times we have a follow-up of some patients where you treat them during the acute phase, reduce their triglycerides. They start feeling better, and when they switch off the drugs, they tend to have high levels and another episode of pancreatitis. So whenever you have a patient with hypertriglyceridic pancreatitis, start him on insulin, heparin, and reduce his triglyceride as early as possible. I mean, that's the, and this have good prognosis. By and large, it causes recurrent acute pancreatitis, does not lead to chronic pancreatitis. So, I think this is a treatable cause, like microliths is a treatable cause. I mean,
should be on
those
a long-term
treatable
drug.
causes should be treated.
Thank you, sir.
Some of the patients with
Yeah.
alcoholic pancreatitis are because of hypertriglyceridemia.
But most of the, that is true, but majority of these patients would not have triglyceride more than 500. So they have a level between 200, 300, 400, but they won't have level which is more than 500.
I think patient with high triglycerides, the important thing when you have acute pancreatitis is a low bicarbonate and lactic acidosis or metabolic acidosis. And that makes them in a very high risk bracket. Most of them have familial type of hypertriglyceridemia,
Correct.
which would have an enormous genetic basis. And phenofibrate, yes, would be required on lifelong basis, and they really do well.
Yeah.
We have faced a couple of challenges when how to treat hypertriglyceridemia induced pancreatitis in pregnancy. We had 2 patients from Nasik, and that was a real challenge, how to handle them. I don't know, they were lost for follow-up, but then once in a while you face these
See,
challenges.
basically I don't know about the drugs which are used, but niacin is a one. Like you have phenofibrate. Phenofibrate itself can cause pancreatitis. So I had a patient who had hypertriglyceridemia. He was on phenofibrate and had developed pancreatitis when his triglycerides were normal. All the other causes were ruled out. We predicted that it is phenofibrate-induced pancreatitis and put the patient on niacin. So I don't know about the safety of niacin in pregnancy, but I think it can be one of the alternative drugs, because many of these lipid-lowering agents are associated with pancreatitis.
Thank you, sir. Thank you for a fantastic talk and for that lively interactive session. I also wish to thank the chairpersons, Dr. Dilip Gupta, Dr. Rajesh Singhvi, and Dr. Abhiram Paranspe for kicking off the proceedings. The next talk is by Dr. Rupjyoti Talukdar. He will be speaking on initial management of acute pancreatitis. And the chairpersons are senior physicians from City, Dr. Jay Deshmukh and Dr. Rohit Kalamkar. And Dr. Nitin Vasnik, senior surgeon from Nagpur.
Well, good morning, everybody. We straight away go for the presentation.
Yeah, very good morning. And at the outset, I'd like to thank the Vidarbha Surgeons Association and DDS Nagpur, Dr. Prasad Bhandarkar, Yogesh, who was with us for 4 years, I think, Professor Mukhewar, for this kind invitation. So I think the first part of my talk has been laid very well by Dr. Mukhewar, by his excellent and very simple presentation. So what you see here is the natural history of acute pancreatitis. There will be necrosis, there will be organ failure, organ dysfunction, and they will require different kind of interventional therapy. Fortunately, only 20 to 30% of patients go through this phase. Now, my job today is to speak on the early management of this patient. So these kind of things we can discuss in the panel discussion on, and in later talks also probably this will be handled. So at AIG, actually being a referral center, we have the opportunity to see prescriptions from all over the country. And when you randomly pick up different prescriptions, these are the things that commonly pops up in the use of these patients in treatment from different centers. analgesics and IV fluids, proton pump inhibitors, antibiotics like up to the tune of meropenem or even 4th generation cephalosporins, things like octreotide ulastatin. So the question is, are all these things really required for in the early management? So that would be a part of the discussion today. And if we look at the natural history, this is what happens. The pancreatic injury happens in the acinar cell to begin with. And then initially in the first week, most of the patients will have something called systemic inflammatory response. Some of them will go on to have multi-organ dysfunction, and this leads to early mortality to the tune of 50% if the patient has organ failure. And during that period, around 20% will go on to have necrosis. But in the second week, some of these necrotic patients will go on to develop infected pancreatic necrosis that leads to secondary organ failure. And that is the secondary cause of death, which is responsible for the remaining 50%. And then 4th week onwards, there will be other complications like pseudoaneurysm, high output fistula, and the complication related to the WON. So what is the goal of early management? So the goal of early management is to try to reduce or improve all these outcomes. So these are the outcomes that are commonly seen, and we need to try to reduce this outcome. And the most important thing is whatever is done within the first 1 to 2 weeks will reflect in the patient's clinical outcome in the later part. So early management is extremely important in these patients. So again, Dr. Mukevar has already talked about this. I'll just skip through. If the patient comes when the patient comes to the emergency, the first thing we need to look is the patient having organ failure or severe disease at the time of presentation. The modified Marshall scoring is an excellent tool now as recommended by Revise Atlanta. If the patient do not have severe disease at presentation, the risk of developing severe disease should be assessed. And we should try to predict if the patient will go on to develop severe disease in the next 2 to 3 weeks. So the risk factors for severe disease are very simple. Just you have to see these 3 things. If the patient is elderly, because elderly patients would have comorbidities that could contribute to the progression of the disease, presence of comorbidity, and obesity. These 3 are established risk factors for development of severity. And again, in obesity, there are many pathophysiological mechanisms like secretion of lots of adipocytokines or peripancreatic, because the peripancreatic fat is metabolically active. So if there is peripancreatic fat necrosis, which happens very commonly in the obese pancreatitis patients, there will be lots of cytokine, adipocytokine secretion that can contribute to the severity. Now, how to predict severity or assess severity? Again, this was mentioned in the previous talk. There are several single parameter and multi-parameter modalities. But the interesting thing, if we look at the study done in 2012, where the group from Pittsburgh had compared head-to-head all the existing severity assessment tools. And if you see here, almost 700 patients, but all the scoring system had comparable performance, and none of them were better than the other. So whatever is available now, like Apache, Ranson, BISAP, SIRS, all functions similarly. So the question is which one to use. We need to have a predictor which is simple, which can be repeated many times in a day, which is cost effective, which is available even in the simplest or basic healthcare centers, like the primary healthcare centers. So to find that, let's take you very quickly through what happens there, how the early pathophysiology is associated, or how can you relate the severity assessment tool with the early pathogenesis. So this is a study that we had published a couple of years back. What we could show was that in human acute pancreatitis, the pancreatic acinar cell behave like an immune cell. The acinar cell starts secreting cytokines once they are getting activated. For example, IL-6, TNF alpha. So the cytokines that are seen in acute pancreatitis first come from the acinar cell, and that leads to progression of the disease. So this is what happens in a normal physiology. These are a cartoon showing zymosin granules. These are something called lysosomes. So normally when there is acinar secretion or acinar activation because of diet, the zymosin will go into the pancreatic ductules. But in acute pancreatitis, when there is an injury to the acinar cell, there is a reversal. So the zymosin, instead of going into the ductules, will come and combine with the lysosome. So in lysosome, there are hydrolytic enzymes that will activate and transform the trypsinogen to trypsin. So there is secretory block and trypsin activation. So this is the first step of acute pancreatitis. And because of this, the whole cascade will begin, which I had already shown. There will be local cytokine expression by the acinar cell. That leads to activation of the circulating mononuclear cell that will come to the pancreas through circulation, that get activated, and that causes a systemic inflammatory response. So this is how the systemic inflammatory response is generated within the first few days of or first few hours of pancreatitis. So there is no role of anti-secretory agent or protease inhibitors, because I showed a slide where I talked about use of octreotide. Octreotide is a anti-secretory agent, ulinastatin, a protease inhibitor. Those things are gone. When the patient comes to the emergency, the patient comes with a secretory block. So there is no role of anti-secretory agent, and the protease activation already happens by the time they come to us. So then that's why there is also no role of protease inhibitor. So by not using this, we are not only saving the patient's money, but we are also saving potential complications of those medications. So this is again how the pancreas starts secreting the cytokines over time, and that is what leads to the systemic inflammatory response syndrome when they come to us. Characterized by a high total leukocytic count, there will be increased respiratory rate, heart rate is more, temperature is more. So many a time what happens, looking at this total count, high total count, it gives a knee-jerk reaction to start antibiotics. But this is not because of infection, this is because of the inflammation that the pancreas has initiated and that is transmitted to the circulation. So initial rise of TLC is not due to infection, and that is the rationale why we should not be using antibiotic on day one, because it's not infection related, it is systemic inflammatory response syndrome related. So now coming back to which could be an ideal predictor or predictor of severity, I had already shown how systemic inflammation is generated. So if you can track the systemic inflammatory response syndrome over a period of time, at least for the first 72 to 96 hours, that would tell us that, okay, this patient is going to have severe disease. And we had discussed about BICEP in the last talk. In the BICEP also, BISAP, the third criteria is SIRS. If SIRS by itself can give us a good predictive response or good predictor, the need for the whole BICEP may not be required. And in fact, Bichian Wu, who actually described BICEP and validated in different studies, also do not use BICEP now. He is also satisfied with only SIRS, because SIRS itself is as good as BICEP. So if we see in this paper, again done by my good friend Vikesh Singh from Hopkins, what he did was, when he studied this patient, as the SIRS score increases, like SIRS score is scored from 1 to 4, all the adverse event, the prevalence of the adverse events were increased. So if 3 to 4 SIRS criteria are present on day one, the increased risk of persistent SIRS is by 4.8%. But if the SIRS is persistent over next 2 days, 3 days, 4 days, this patient is going to have severe disease. So we have to be very careful for these patients. If need be, shift them to the HDU for a closer monitoring, at least for the first few days. So this is the summary of the severity assessment and prediction. So extra attention should be given to obese patient, elderly, those with comorbidities. Serial monitoring of SIRS has to be done to see if it is persisting or worsening over the next 48 to 72 hours. Now coming quickly to the early management, the first thing is obviously pain management, and all these years several pain analgesics had been in use. Now we have two good studies from India. This was from Pramod Garg's group that was published, I think last year, where they could show that they compared pentazocine, which is a kappa opiate receptor agonist, with diclofenac. And they showed that there was a longer pain-free period with the use of pentazocine, and there was a significantly decreased requirement of salvage analgesia using fentanyl. Similarly, a study from Rakesh Kochar's group from PGI Chandigarh that was published a couple of years back also compared diclofenac with tramadol, and both of them had equal efficacy in pain reduction, and there were no adverse events. So now we have at least tramadol and pentazocine for use in these patients. Diclofenac I would personally not use because of its nephrotoxic potential, and it can also cause GI adverse events. As it is, the patients are on stress, in stress, and pancreatitis itself can lead to gastric and duodenal changes. So this may adversely affect. So the key words for early management is fluid therapy. I am writing aggressive here, but in the next few slides I'll say why we should not use the word aggressive now. Early enteral feeding, the gut has to be kept moving, no prolonged rest, and avoidance of prophylactic antibiotics. So what do the guidelines say about fluid therapy? If we see here the AGA and ACG guidelines, there were earlier studies which showed that lactated ringer was a better solution than a normal saline, but the AGA has no recommendation and ACG has a strong recommendation in favor of lactated ringer. And how to monitor this fluid? Monitoring and titration is a conditional recommendation by the AGA and weak recommendation by ACG, because there is no valid ideal tool to monitor and say that the patient is going to have adverse events or is being affected. So what does the evidence say? After the first lactated ringer paper from again Bichi and Wu, there has been several other papers which have shown that there is no difference between lactated ringer and normal saline in reducing SIRS and organ failure. Both are similar. And now many people are studying something called plasma-lyte. Maybe many of you are using plasma-lyte, which also could be as good as lactated ringer. We don't have hard data on that now. But the main question is, can fluid harm these patients, or can aggressive fluid harm these patients? So earlier the Chinese were actually saying don't give IV fluid, and aggressive IV fluid, they may harm, they may cause capillary leak syndrome, ascites, abdominal compartment syndrome. No one in the world believed them, because in those studies they were also using traditional herbal Chinese medications and many other things. But then this systematic review came with more than 2,000 patients, which showed that high fluid rate increased the number of serious adverse events, mortality and incidence of sepsis. So this meta-analysis actually hinted that yes, aggressive or over-aggressive fluid therapy can be harmful, and that was further validated in the recently published waterfall trial, where the trial had to be terminated after 1/3 recruitment in the first interim analysis. Why? Because firstly, there was no significant difference in the primary outcome, which is expected. In interim analysis, it may not happen. But what was more ominous was there was a significant higher incidence of fluid overload in the aggressive fluid therapy. So this clearly tells us that aggressive fluid therapy can be harmful to the patients, and fluid therapy should be modulated and regulated. So fluid therapy is essential, but it should be monitored and goal directed. And what are the goals? There are simple clinical goals. Just urine output of 0.5 to 1 ml per hour has to be maintained, 65 to 85 mm of mean arterial pressure. The status of SIRS, is the patient having persistent SIRS, or if the SIRS is coming down, and then lung ultrasound for B lines. That's a simple tool that anyone can do at the bedside now. If the lung has B lines, that means the patient is having fluid overload. You should be careful. And the role of fluid therapy is limited after 72 hours. Whatever fluid therapy you have to do, it has to be within the first 72 hours. After that, there is no role. So this is a basic, simple algorithm based on the waterfall trial that we can use. The patient can be started with either RL or normal saline at a rate of 1.5 ml per kg per hour. If there is hypovolemia at presentation, then a bolus of 10 ml can be given. At 3 hours, if the patient has signs of fluid overload and the fluid should be decreased or stopped, and if it is well tolerated, infusion should be continued. These are the checkpoints at 6 hours, 12 hours, 72 hours. If the patient has hypovolemia at this point, give a bolus and then continue same way. Normovolemia, the fluid rate should be reduced, and stop infusion after 20 hours of oral feeding initiation. And if there is overload, you have to stop the fluid or reduce the rate of infusion. Now coming quickly to nutrition, again, there is a tendency to ask the patient not to eat food, and we wait, or tendency to wait for pain to go off or ileus to go, bowel sounds to come, and then only patients are started on feed. There is a problem in that practice, because prolonged NBM can cause two things. One is gastric colonization by enteric bacteria, and this is again aggravated by the overuse of PPIs. That's commonly used everywhere in the ICU, in the ward, lots of PPS acid suppression, so colonic organization, gastric colonization, and there will be alteration in the gut barrier permeability. So this leads to gut bacterial dysbiosis, and that could finally lead to infected necrosis and secondary organ failure. So the goal of early feeding is to avoid bowel rest, maintain gut barrier integrity. In the first 48 hours, we do not need to give calories to the patient. They already have, because of the hypercatabolic response, they have lots of glucose running around. That gives them the calorie, but the gut integrity has to be maintained, and simple thing to do that is start off with sips of water. Even on day one, if the patient is tolerating, just start with sips of water, so peristalsis keeps on happening. And if peristalsis happens, the ileus will go away and the gut barrier will be maintained. And of course, towards the later part, after 48 hours, adequate calories and nutrition has to be done. So again, if we look at the guidelines, the guidelines again recommends strong recommendation for enteral feeding. Again, if enteral feeding is not tolerated in 48 to 72 hours, NJ or NG feeding, assisted feeding can be done. And again, this I'll skip because of lack of time. So again, this was a nice trial from the Dutch group, which compared early group feeding and on-demand group feeding. And in the on-demand group feeding, almost 70% patient tolerated an oral diet and did not require tube feeding. So if the patient wants to eat and the patient do not have a very severe disease or they tolerate, they do not vomit out, those patients can be started on oral feeding early on. So now another important question, I don't have much time. So can prophylactic antibiotics or avoiding prophylactic antibiotics improve outcome? So if we look at all the studies that has been done, the double-blinded randomized control trials did not show any benefit of prophylactic antibiotic in prevention of the adverse outcomes, infected necrosis. But these studies had several issues. Most of these studies had issues with the study design, selection criteria, duration of treatment, type of antibiotics, and the outcome assessment. All these are very heterogeneous. So it's very difficult to say if it will really help or if it will really harm. Again, if we look at the guidelines, because of that, probably the AGA is giving a conditional requirement based on low quality evidence, and ACG is giving a strong requirement based on moderate quality evidence. But what happens in real life practice? This was a study that we had conducted. I don't know if Yogesh was there during this study or not. We did a national survey. We had a program called Pancreas India. Through that program, we did a national survey of different centers on the use of prophylactic antibiotic. 67% of these patients got antibiotic, and out of those 67%, 66 got prophylactic antibiotics. So majority of them actually got prophylactic antibiotic rather than therapeutic. And if we see here, even for mild acute pancreatitis, the patients were getting beta-lactams and even third and fourth generation cephalosporin. So why, and this is not only that is happening in India, it's a global phenomenon. All over the world, different countries use prophylactic antibiotic, which is not probably required. So what is the harm? What the harm can happen here? So this is a study that we looked at the WN fluid. When a WN fluid drainage was done by PCD or by endoscopic ultrasound, we looked at the fungal dysbiosis, because many of these patients, even after antibiotic therapy, even after good drainage, they do not do well. They continue to fare worse. So we looked at the fungus, and what we found was there was significantly increased abundance of several fungus, especially something called Malassezia, Candida tropicalis, and penicilloides, Aspergillus penicilloides. Those three were overtly present in the fluid. So where did this fungi come from? So this is where we looked at the stool, the blood, and the WON. If you see here, the fungus, like especially Aspergillus, was growing more in the stool, probably because of the inflammation or antibiotics that came to the blood, and then it came to the WON. And that was because of there was alteration in the gut barrier permeability. Because of the altered gut barrier, the fungi in the intestine translocated to blood and colonized in the WON. So probably one of the factors could be because of overuse of antibiotics in these patients, why the fungus had grown. So I'll just take maybe 2 more minutes. So this I can skip. So the antibiotic summary here is blanket antibiotic prophylactic cover should not be given to this patient. And again, I have shown in one of my earlier slides, the early high total count is because of inflammation, not because of infection. And that should not give us a knee-jerk reaction to start antibiotic on day 1. Problem is, if we start the antibiotic and if we do not have an outcome or we do not know when to stop, it will keep on going. And that leads to all this adverse outcome of fungal infection. So if the patient has acute necrotizing pancreatitis, again, even then, no prophylactic antibiotics in the first week. In the second week, if the patient shows signs of infection, again, by rising TLC, persistent SIRS, air bubbles on the CT scan, empirical antibiotics can be done. And later on, if drainage is done based on the culture sensitivity, the antibiotic can be titrated. So again, this is a recent study, I'm sure all of you know, based on procalcitonin guidance, antibiotic therapy can be started or tapered off. If the procalcitonin, serial procalcitonin is more than 1, antibiotic can be added, escalated. If it is less than 2, it can be reduced. A very good study from Manchester. Now, again, just quickly, if we see here, why all patients of necrosis do not get infection. Only a small proportion gets. So there has to be something which is playing here, and HLA-DR is something which is responsible for immunosuppression. And when we looked at this study, the patient who had persistent downregulation of HLA-DR, role of HLA-DR is to present bacteria to the, or bacterial antigen to the immune cells. So if the HLA-DR is downregulated, these patients are at 11-fold higher risk of developing infected necrosis. And to add that further, we again currently this study is under review. So if the patient has a very low plasma tryptophan, which is related to kynurenine, something called kynurenine related to anti-inflammatory response and immunosuppression. So if the tryptophan is less than 9 nanogram per ml, these patients are possibly having infected necrosis. This is under review, and probably this could be one of the future biomarkers of infection. So finally, ladies and gentlemen, the some other ways to improve outcomes is there are no evidence of Rayleigh tube aspiration anti-secretory. I already talked about this. Prokinetics, aggressive fluid therapy may cause harm, Foley catheter may cause harm, probiotics, prophylactic antibiotics may cause harm. So I'll skip this study that we had done on the thing. So finally, this is my last slide. So how to improve outcomes? The summary would be patients who are elderly, who are obese, who have presence of comorbidity, be extra careful with them, monitor them extra, if need be, put them in the HDU or ICU for early monitoring. Persistence of surge should be monitored very meticulously. It's something that can be done 5, 6, 7 times a day, any number in a day. So that can be, and it is not expensive. Goal-directed fluid therapy within the first 72 hours. Avoid prolonged bowel rest or prolonged fasting. Enteral feeding within 24 to 48 hours. If they do not tolerate by 72 hours, put them on an NJ tube. And avoid prophylactic antibiotics at least within the first days, and avoid Foley catheterization. So this is the end of my talk, and these are several people whom I have to acknowledge for their work and for the data that they have generated, which I showed today. Thank you. We'd be happy to take questions.
Well, thank you very much. I have 2 very quick questions. Is there any change in management when you have acute pancreatitis or acute on chronic pancreatitis?
Yeah.
And number 2 is that not directly pertaining to the phase of acute pancreatitis that you have narrated, but what is the role of antithrombotic agents, heparin? Where do you initiate them?
Yeah.
Or it's a bit a gray area right now.
Yeah. So answering the first question, the basic management of acute and recurrent acute are same. Good thing is, acute on chronic. Good thing is acute on chronics are less severe because they already have a fibrotic pancreas, so they do not mount an extreme inflammatory response. So it's kind of easier to treat acute on chronic, but basic principles are the same. Secondly, starting antithrombotic is not recommended in routinely. 2 problems in that: many patients will have necrosis, and if because of that we happen to have a bleed in the necrosis, then so if the patient has progressive venous thrombosis, mainly the portal vein with symptoms, then they can be started, but routinely it's not recommended.
Can I ask? Hello. Sir, you said about the pentazocine.
Yeah.
Use of pentazocine in such patients. What is the effect on sphincter of Oddi and intraductal
So I
pressure?
expected that question, and it's good that you asked for it. So pentazocine is a dual in both kappa and this inhibitor. So the sphincter of Oddi obstruction by pentazocine is not as high. Morphine derivatives will cause that, but pentazocine, because of this dual role, it don't do that.
Another thing is what we have seen is monitoring regular blood glucose levels in patients of pancreatitis, and keeping it below 140 makes good outcome of pancreatitis.
Yeah, so agreed. But initially there will be, I think in the first 48 hours you should not try to chase the glucose too much, because it will come. But later on, yes, we should try to, and the good thing is if we do enteral feeding, glucose will be maintained. But if we do parenteral feeding, again, which is not recommended, that again causes hyperglycemic spikes.
Nice talk,
Thank you,
Rupjyoti.
Yeah.
You highlighted the very important points of management. I have a few comments that majority of the times when we see patients with acute pancreatitis, they come to us after 72 hours.
Yeah.
So they come late. So fluid therapy has to be at the primary level, and this is the right platform to tell to the patient that can be done at peripheral places from where the patients are referred, because that's a very important point where you prevent development of severe pancreatitis. And in your practice, did you had an occasion of giving epidural anesthesia for pain in acute pancreatitis?
So sometimes we have to use, because some patients are very refractory to all the analgesics, even nalbuphine, and so in those we give short courses of epidural, and that seems to help. We don't use too often, but yes, we have experience with few patients. It does help. But then the anesthetist has to be careful, because if the needle goes into the retroperitoneum, so it might induce actually infection in that necrotic tissue. No, I mean, so that's why that is important.
Yes, unlikely.
Unlikely, I agree.
Epidural, unlikely.
I agree. I agree.
I don't like.
Yeah.
Thank you so much.
Thank you.
Thank you, Dr. Rupjyoti, for a fantastic talk.
Thank you.
From basic research to advanced clinical science. So next is a panel discussion, and Dr. Yogesh Bang is going to moderate the panel discussion. And may I invite all the panelists, Dr. Amit Maydeo, Dr. Rupjyoti Talukdar, Dr. Sadiq Sikora, Dr. Sudhir Tome, Dr. Rajesh Mundara. I'll be joining.
30 minutes कर देना time. Good morning, everyone. Thank you for being here this Sunday morning. So, all the panelists, you are seeing the screen perfectly fine in front of you. So, as we evolve. Okay. So as we evolve in the treatment of pancreas, as acute pancreatitis, like 25 to 30% of these patients, they land up with peripancreatic fluid collections, and the main aim after like 3 to 4 weeks is to how to manage these. So let me start questions directly. Rupjyoti sir, please classify the peripancreatic collections based on what we are seeing there. How do we classify peripancreatic collections now?
Yeah, so this picture that you have shown is based on the revised Atlanta. So there could be two main collection. Initially, within the first 1 week to 2 weeks, there could be just exudation of inflammatory fluid around the pancreas, which is called acute peripancreatic fluid collection. And then the other could be, so what you see in the, so in the first picture only, there could be pancreatic necrosis or peripancreatic necrosis.
That one.
If the APFC persists up to 4 weeks or 1 month, which is very rare in, so it is defined as a pancreatic pseudosis. So basically, since those are free fluid, they do not contain necrotic debris, these are clear fluid, and usually they are getting absorbed by the end of 4 weeks. But if the patient has peripancreatic or pancreatic necrosis, initially it will be a dense, hypodense looking collection on CT. But over time, it will be gradually getting liquefied, liquefaction happens, and then it will contain a liquid which contains necrotic debris. So within the first 4 weeks, it will be called acute necrotic collection with necrotic debris, but after 4 weeks, there will be a well-defined wall and it will be more liquefied with necrotic debris. That is called a wall of necrosis.
Yeah. Thank you. Dr. Amit Maydeo, sir, what is the significance of this? Why do we need to understand these 4 classifications, and how does it change our management in the patients, like peripancreatic fluid and peripancreatic necrotic collection, and then walled off necrosis and pseudocyst? How does it make difference? Why this classification has changed our outlook to these collections?
There are two reasons. Number one is whether we need to intervene. Number two is when to intervene.
Yeah.
And number three is how do we intervene.
Understood.
These three factors get affected dependent upon these classification of the collections.
Right, right. So when do we intervene in acute pancreatitis collections? When do we intervene? Dr. Sadiq sir, when should we intervene? Any peripancreatic collection, what should be the indications of intervention?
So most often the peripancreatic fluid collections don't need intervention.
Yeah.
The mere presence of them don't need intervention.
Yeah.
So it's primarily related to symptoms and the complications with these collections are inducing.
Great.
So generally, any intervention is required beyond first week or even in second week. If the patient is not improving, new onset problems or evidence of infection.
Agree.
In that situation, it requires intervention, and then based on the location, you need to decide what kind of intervention is required.
All right. So any change in clinical scenario or any, yeah, Amit sir, please.
So as he rightly said, intervention is only for symptomatic collections.
Collections.
Asymptomatic collections, conservative treatment.
Agree.
There is no question about
Agree.
that.
Agree. So any infected collection or a necrosis or any non-infected with ongoing organ failure or symptoms in the form of like obstruction, persistent unwellness, these are the indications in which we have to intervene. So we'll come to cases now. So this is a young male. He has a 1 week history of abdominal pain, significant distension and breathlessness when he presented to us. Examination revealed pulse of around 140, blood pressure was 90/60, 101 fever. The abdomen was grossly distended and there was a edema over the abdominal wall. Patient's counts were 18,300, creat was 1.6. Liver function tests were normal. I'll show you the CT and then we'll discuss what has to be done for this patient. So this was the patient, 31-year-old male, grossly distended abdomen, respiratory distress and high-grade fever. Within a week, he had presented to us with this. So Dr. Tome sir, what do you see here? What is the problem and what has happened to this patient within a week?
This looks like a very severe pancreatitis from all the criteria which are seen there.
Yeah.
And he definitely is going in for ventilatory needs. And he has, it appears from this, his intra-abdominal pressure should be monitored.
Yeah.
And he's going in for compartment syndrome.
Okay.
And some strategy should be done immediately for reducing compartment syndrome
Okay.
in the
So
form
this
of
was-
drainage of fluid at least.
Yeah. So this was basically a severe necrotizing pancreatitis. The patient had respiratory distress, respiratory rate of 40. It was basically an abdominal compartment syndrome within a week. And it is one of the indication of early intervention, and we planned for pigtail placement for these patients. So what are the indications of early intervention? Dr. Rupjyoti sir, as we have discussed this again, I'll go ahead. Dr. Rajesh sir, can you tell us what are the techniques of drain placement and what are the drains which you use? Here comes the role of IR people. Yeah.
Most of the patients are sick, and if we have an ultrasound and in such large collection, the procedure can be done bedside. Larger collections can be drained very easily with pigtail. Maybe I would still prefer Malicot catheters.
Yeah.
For 14 and above, maybe 16, 18, the largest cavity, if it is not septated, the largest cavity we drain first. If we find septations 2 or 3, or we find 2 or 3 different cavities, large cavities, we can drain 2 or 3 collections at a single go.
Right.
So that the patient is tolerates.
Image guided placement of a drain and preferably wide bore drain as much as wide possible. We in fact nowadays have started putting directly the surgical drains under ultrasound guidance for these patients rather than Malicots, because the wide bore and the number of holes are better. Yes sir.
Early intervention like this, what you showed me, what percentage of your patients of acute pancreatitis you need to do this?
No, hardly, like I don't, less than 10% or less than 5%.
This is a negligible percentage.
Yes, yes, yes.
Most of the times, whenever there is a early fluid collection, whatever be the severity of pancreatitis, conservative treatment works the best.
That
And
is
you have to
agree.
delay as much as possible.
Agree.
So
Agree.
it's very, very small percentage where you have to go so early and start putting big drains.
Agree. So we don't see any of patients, like once in a 6 months we might be seeing any patients who might need a pigtail or a drain placement that early. What are the follow-up of, what is the protocol for follow-up imaging of such patients? We have put a whiteboard drain, patients has improved, but still any role of doing a follow-up imaging, Sadiq sir, for such patients?
So, we have seen the collections. I generally don't want to do multiple drains at one time. I discuss with my IR person and target one large collection, then see how the response is, and subsequently, add more drains and upsize them.
Yeah.
That's how we would do. And of course, clinical follow-up is important in
Right.
terms of how the patient is behaving,
Agree.
and then decide about any further intervention if required.
Right.
The culture sensitivity of drains is important because sometimes you may have early infected collections, and that may have a prognostic implication subsequently.
Agree.
As far as imaging and follow-up is concerned, it's primarily in discussion with IR, but usually we don't do multiple CT scans. We would follow up with ultrasound imaging.
Yeah.
And only if the patient is not improving, new onset symptoms, or if there is no resolution of these collections,
Symptoms.
then
The undrained one have to be seen if the patient is not
cross-sectional
improving,
imaging.
or if the patient has improved and again started showing some
Exactly. Then
change.
cross-sectional imaging.
Right. So we discussed this about nutrition in last talk. We'll skip this question. 2 weeks later, this patient had a significant regression, as you can note here, and patient was afebrile. He tolerated the normal diet and then was discharged with pigtail in situ. The drains were removed after 4 to 6 weeks for this patient. He didn't have any pancreatic fistula, and he improved with that. So coming to the question which we discussed already, the ideal time of intervention should be ideally delayed as much as possible, not 4 weeks, as much as possible, beyond 4 weeks. Let the collection or necrosis get good walled off, and then do the intervention. And we have learned this from this study where early intervention had shown a significant high mortality rather than the delayed one. Coming to this next one, this is a patient who presented to us in January, 54-year-old male, ethanol-related acute necrotizing pancreatitis. He just presented with 4th week. He had pain in upper abdomen, yellowness of eyes and urine, no fever, and examination revealed icterus, a palpable lump in epigastric region with extension onto right subcostal region. The total counts were 8,300, bilirubin of 6.7, direct bean 5.1. Alphas was 321, OTPT were normal. We'll have a look at the CT here. So, young patient, 54-year-old patient with jaundice and a palpable lump. And this is just the 4th week which has started. So, Prashant sir, what's there in this CT? What are, I'll run that again.
So there's a pseudocyst there near the head region.
Yeah.
I think it's causing a good compression in the antroduodenal area, I guess.
Right. So
And,
what should be the plan? I'll ask everyone this. In this patient, just a 4-week jaundice and a palpable lump. What should be the treatment plan? Only placement of nasojejunal tube for feeding, a nasojejunal tube with ERCP to palliate the to decrease the jaundice. US guided drainage for this collection, or wait and watch. Patient doesn't have any fever, the counts are normal. Sadiq sir?
The patient certainly has a symptom of jaundice, which is quite high bilirubin. We could see the dilated IHBR, distended gallbladder. I would like to know on ultrasound whether there were any stones in the gallbladder,
Right.
or whether it is primarily due to compression. Most likely it looks like compression. This patient needs intervention, I have no doubt in my mind.
Okay.
And this patient should have, looking at the way it is, it could be drained by endoscopic intraluminal intervention.
Okay.
I'm not so sure it's only a pseudocyst. There could be necrosis along with fluid collection in this, because it looks like not a very clear fluid, at least on imaging on CT scan.
I guess most of us agree, or most of you agree, for some intervention in form of EUS guided drainage of this collection. So we actually thought of wait and watch approach, because it was just a 4th week and we thought of placing a nasojejunal tube only. So this endoscopy was done. Actually, the gastroenterologist attempted an ERCP for this, but I will just show the video in front. Okay, it's not going ahead. So ERCP was not feasible for this patient, and there was a large bulge which you could note into the duodenum. The walled-off necrosis was bulging into the duodenum, as we can see in the CT also. So just a nasojejunal tube was placed for this patient, as patient didn't have any fever. We managed him with just painkillers and tube feeding. What happened on 20th of January? The CT was of 11th. Patient had a sudden onset tachycardia, 130 and hyper.
Can I ask the endoscopist that, would you attempt ERCP in this situation?
Yeah.
No.
Yeah.
Attempting ERCP itself is wrong, because the duodenum is going to be deformed.
Yes.
Passage to the papilla is not going to be easy. What you have to attempt, if at all, is drainage of that collection. Fortunately, it is beyond 4 weeks.
Yeah.
It's just 4 weeks, or it's 4th week. EUS has to be done.
Agree.
And with EUS, you have to identify the perfect spot, and you should put a nice lumen opposing metal stent. With that, once the cyst or whatever collection regresses, jaundice is going to go away.
Okay.
Because of extrinsic compression.
Yeah. And EUS would also ensure if there is an intraluminal obstruction by a small microlith or stone.
Yes, yes.
So that would be an additional.
Everything you can see, you can scan with EUS.
We can see the CBD also and ascertain whether it's a gallstone or it's a compression. So
and the necrosis can be more nicely picked up on EUS just before your intervention.
Necrosis you can't pick up so well on a CT or even on an MR. Endosono is the most accurate to pick up necrosis.
Yeah, so you talked about lamps, but if there is no much necrosis, this would be a good candidate for double pectoral plastic stents.
If it is a plain pseudocyst, then even plastic stent will work.
Yeah.
Okay. So 1 week we waited more, and on 20th of January, patient had a sudden onset tachycardia in the morning and hypotension. The tenderness had increased and palpation lump size also got increased. So what might have went wrong, and what we should do? So
bleeding is what comes to mind.
Yeah. So as we just discussed, any change in clinical scenario, get a cross-sectional imaging again. So here we can see some increase in the size and some hyperdensity in the cyst. So Dr. Rajesh, can you comment on that? What should be done for this patient? We are seeing some hyperdensity and an increase in size of that cyst.
I would get a CT angio done itself.
Yeah.
A CT angio would reveal some pseudoaneurysm over here.
So actually, I don't have that image of CT angio, but there was some pseudoaneurysm which we could see, and there was a bleeding through the vessel which was taken care of with IR guided imaging. So here there was a bleed which was happening into the cyst.
Yes.
So the patient had actually increase in the size of cyst and tachycardia, hypertension. That was an indicator that something has gone wrong. And then IR guided, Dr. Mundara can comment on that.
Coil embolization of the bleeder can be easily done.
Yeah.
And once you embolize it with coils, the bleeding will stop very easily.
Right, right. So that's how it was managed. On 22nd Jan, 2 days later, pain decreased, tenderness decreased, the lump size decreased, patient had loose motions, but now patient started throwing fever. The fever now is around 101 and multiple spikes. And we did just a plain CT to see why the fever has started now, and now we can see the size has decreased, and there is some gas in the collection now. So is it something which is common after any intervention, or?
But the patient is throwing fever, right? So
Yeah,
if patient is
started.
throwing fever, means it is an infected cavity, which
Yeah, it
requires
has
some.
infected. So what should be done as the size is decreasing? Should we still put some metal stent, or just wait and watch and give antibiotics to these patients?
You can attempt antibiotics first.
Okay.
and see whether the patient's condition is stable or deteriorating. But if the patient continues to deteriorate, then you will have to intervene and remove that infection.
So at least 48 to 72 hours, we tried antibiotics. The fever started coming down. Patient's clinical status improved significantly. So we just continued the patient on nasojejunal feeds and antibiotic.
And there were some air bubbles also, right?
Yeah.
So did we do a cologram and see if there is any colonic communication?
We clinically felt it is something which has fistulized into duodenum probably. That's why.
Yeah. So I think in all likelihoods it has ruptured.
Yeah.
It has ruptured into the viscera.
Yeah.
That's why the size has come down, loose stools are present.
Yes, yes.
There is air in that.
Yes.
So all that points that it has spontaneously ruptured.
Yes.
And it's not a very good situation, to be very honest. Internal rupture, in terms of that if subsequent intervention is required, it would make it more complicated.
More complicated. So why we thought of delaying was this basically a paper in which immediate versus postponed intervention for infected necrotizing pancreatitis was studied, and what they found was that immediate catheter drainage was not superior to a postponed drainage for preventing the complication. In fact, postponed drainage had some fewer interventions. So this is something which we thought of and we think of whenever we look at just a 4 weeks time period. Of course, this was a large and a symptomatic one. We could have done a US guided drainage, but this patient was managed with just NJ feed, and he had some other complications which needed treatment. Coming to the next case, this 26-year-old male, 17th July, he presented with acute abdominal pain, admitted with acute necrotizing pancreatitis and was managed conservatively in the initial phase. Then 7 weeks later in September 21, he came with mild abdominal pain. There is no fever, total counts of 11,200. So look at the CT. Just a mild abdominal pain at 7 weeks. Amit sir, what should we do for this collection? I'll run the CT again.
So symptoms are not much.
No, only mild abdominal pain. He had just come because he started having pain, so he came for follow-up. Counts were 11,000. He was tolerating soft diet and liquid everything he was eating.
So what is the necessity of trying to drain this collection?
Yeah, so there is no necessity for that. That's what I wanted to know. So there is no necessity. We don't give any IV antibiotic to these patients, as already discussed. There is no need of drainage. We just have to follow up. We learnt about this in the last talk. There is no need of antibiotic to prevent any infection or anything. 1 month later in November, at around 12 weeks, now the patient has come with abdominal pain, vomiting, 3 to 4 episodes of loose stools and a low grade fever. The pulse was 90 and TLC 13,400. CRP is raised, and now the collection has started throwing gas. So it's an extensive gas around the stomach, you can see there. And the gas is extending into the mesocolon as well there, coming into the area. So now he has fever, pain, counts which are raised, and that much gas. But the fever is just low grade and the pulse was 90. So we should go in immediately drain or just start the antibiotic and wait and watch. Again, that same question which we had in last scenario. Dr. Prashant sir, what will you do for this patient?
I think again you can give a trial of antibiotics and then wait for about 48
so the same thing
hours.
was done for this patient. We went with the approach of giving an antibiotic at least for 72 hours and then wait and watch. Meropenem was started, and after 2 days patient was afebrile. It was having a normal pulse. He was tolerating liquid to soft diet. So we continued the same treatment and didn't do any drainage. So as we know, nearly 80 to 85% are mild, some 15 to 20 are moderate to severe, and 30% of these patients may land up with infection which needs treatment. But we also know that nearly 30 to 35 or nearly 40% of the patients spontaneously resolve, and that's what we have discussed till now. Coming to now interventions. So 31-year-old male.
Yogesh,
yeah.
I mean, I'm not so convinced about the argument which you put in this particular case.
Okay.
Here's a patient at 12 weeks who has collection, which now seems to be infected in all likelihoods, in view of the air and all, and the location of it, this is the appropriate time to drain this patient's collection. Because
No, but
it's
if the
12
patient has
weeks.
stopped throwing fever after 72 hours of meropenem and all, if the patient is eating well, there is no pain, there is no tenderness, no outlet obstruction, no symptom,
So,
he is roaming in the
again,
ward.
This is an infected collection, central, placed, has high potential for ongoing complications. I mean, in one-off, you've done well, but I'm not sure that each time you would get that result in these patients.
Okay.
And it is the right time in terms of the timing over a period of following up a patient of acute severe pancreatitis to reach this point. And this may be a good opportunity to drain this patient because the prediction of outcome is uncertain in this.
Okay.
And the indication for drainage is clear and evident. So
Clear.
I would choose to drain
Okay.
it.
Okay. So, considering that patient was relatively asymptomatic just with 2 days of antibiotic, we thought of following in up, and at 1 week follow-up of, we did a plain CT, it showed significant regression, so the patient was discharged with that. So coming to this 31-year-old male, abdominal pain of 1 day duration on 5th of September, evaluation showed ethanol-related pancreatitis. He was referred to us on 7th of September. He was having persistent organ failure, so was labeled as a severe acute pancreatitis, was managed conservatively and was discharged on 23rd. As we can see there, the creat was persistently high for a particular long duration of time. This was the CT which was done in the initial presentation. It showed edematous pancreatitis mainly, and some fluid collection which was trickling down along the perinephric plane there. So this patient came to us after 6 weeks with fever and chills, a lump in left lumbar and left iliac region. Counts were raised and there was no renal failure. This is the CT as we can see at after 6 weeks. The left kidney is pushed up and there is a, this was the collection which was causing symptom to the patient in form of pain, tenderness, and fever was there with chills. So what would be the ideal way to tackle this collection?
This is best tackled percutaneously in a retroperitoneal approach.
Yeah.
And if you tackle that, that drain itself is sufficient. Sometimes what we do for such a collection is through the tract which the radiologist makes, we dilate the tract and put an expandable metal stent, esophageal stent through that.
Yeah.
And through that we can put a scope.
Okay.
And clean up the whole thing.
Yeah, so percutaneous endoscopic necrosectomy or a ward also can be done. So the patient after 3 weeks, we did put a wide bore drain. After 3 weeks, he continued to have low grade fever, pus of around 120 to 150 ml. Total counts were still raised and the CT showed this. As you rightly said, this patient had persistent collection, so he needed further intervention. Sorry. Yeah. So basically, the cavity which was drained, nearly 60% of the cavity got drained, and there was sump which was still remaining with a gas pocket in that. So that needed further intervention. So this patient was actually managed surgically by retroperitoneal drainage, video-assisted retroperitoneal drainage. So you can see the gas which is coming up and that wide bore drain which was placed. So the videos we'll be seeing in the next session, video assisted. So which interventions? We have already discussed this. We can have endoscopic, radiologic or a surgical or sometimes even hybrid approach. And we always think or talk of step-up approach. What is this step-up approach? Dr. Amit sir, can you explain that?
Step-up approach is basically for walled-off necrosis.
Yeah.
Once. So what we do is basically under US guidance, we just drain the collection by putting a lumen opposing metal stent. When it is a WON, we don't put just plastic stents. It is always a metal stent, lumen opposing metal stent. But along with the lumen opposing metal stent, to prevent clogging of the stent with necrosis, inside the metal stent we put pigtail.
Yeah.
So that it doesn't get clogged. This is the first step. With this, if everything settles down, then it's fine. Then we just wait until all the collection goes away, the necrosis becomes organized, patient improves, and then afterwards you can just pull out the stent. If the patient doesn't improve and the necrosis keeps on coming and clogging the stent all the time, then step up approach means through the stent you go in with a scope and we do necrosectomy.
Right. So based on that, that's what is the step-up approach. That is what is used. Why this approach has come up? What was the reason why we thought of going? Why not put a SEMS and go in and remove all the necrosum immediately?
Because it is not required in all the patients.
Okay.
And number one, and number two, if you are going through the stent again and again with the endoscope, you can dislodge the stent and you can create complications.
Okay. Okay. So basically this step-up approach as compared to for open necrosectomy earlier, as we used to do, this trial, Panther trial which had come up, it had shown that nearly 30 to 35% of the patients just with the drainage can improve. Even by putting a LAMS or a percutaneous drain, nearly 30% of the patients might improve, might not need any further reintervention. And directly going for an open necrosectomy and versus if we just step up, the chances of having major complications are significantly less. That's why the step-up approach had come up. Coming to this biliary pancreatitis male, 7 weeks, abdominal pain. There is a tenderness in upper abdomen, counts are raised. Creat is 1.1. Dr. Prashant sir, just have a look at the CT. And what would be your opinion on this? So this male patient has biliary pancreatitis.
Yeah, so there seems to be collection behind the stomach. Probably some necrosis might also be there.
Yeah.
So this is the 7 weeks and he is having fever. It's the right time to intervene with endoscopic approach, as Dr. Amit has been suggesting, one-step lumen opposing metal stent, US guided puncture. Yeah. And then follow the step-up approach if necessary.
So an EOS guided puncture and this placement of metal stent was done for this patient. We'll show this in the video session to you next. So post procedure, first 72 hours, pain decreased, fever came down to 100, but counts were 12,300. But after that, patient started throwing again high-grade fever. Many a times this is what we see after placing the stent. TLC got up and patient's general condition was a bit toxic. So as Dr. Maydeo suggested in last time that we have to go in and start doing necrosectomies for these patients. So on an average, how much time or how many interventions are needed for such collections, sir? Amit sir?
2 to 3 times you have to go in.
2 to 3 times you have to go in. And
on
every
average
time?
Is 2 times.
Okay. So
the issue here is, you know what, we still do not have a perfect instrument to catch the necrosis and pull it out and dislodge the necrosis.
Okay, just a thought, Dr. Sadiq sir, this was actually asked to me by one of the surgeons, that if a biliary pancreatitis and such a large collection is there, can it be tackled laparoscopically, both the things together, gallbladder as well as a laparoscopic cystogastroscopy?
I mean, that's an option, especially when you have to do a cholecystectomy. But when I saw the CT scan, the extent of inflammation and all, omental thickening, all that, it doesn't augur well for a surgical intervention in such situations.
Agreed. So,
but if it is not there, I would be happy to do a transgastric drainage, as they would say,
right.
do endoscopically, and take care of the gallbladder also, which needs treatment at some point of time.
So that can be done once the necrosis
One
gets away.
quick cross talk between the panelists. Do you use hydrogen peroxide during necrosectomy, Amit?
Sometimes we use, but there is nothing much benefit. So just what we do is we try to cut the necrosis by using a snare, and that we are finding the best. And now there is a very new instrument which we have taken, which is called endorotor, which is actually like a rotablator, what you use in angioplasty. So that endorator rotor you can pass through the scope and it actually pulverizes the necrosis, and then you can keep on sucking it out.
So a single setting laparoscopic approach for such patients is actually not feasible. It's not feasible many a times. You can't get an access into the abdomen. You can't create that much pneumoperitoneum To talk of it, it's simple, but doing it actually can be a difficult option. So, as I said, so this is how we evolved in the necrosectomy. We went from an early to delayed, then we went from open to minimal invasive, and now we have come to endoscopic approach. So, what does all these things conclude, whatever we have seen the cases? So, we all know that step up is the treatment of choice. We should always try for step up. Step up could be an endoscopic step up, it could be a surgical step up based on the location, as Dr. Amit rightly said. Endoscopic has always an advantage over surgical in reducing the pancreatic fistulas. So this is what most of the studies have shown, endoscopic versus surgical, whenever we talk of, that the pancreatic fistula rate after surgery is more. Naturally, we are putting a drain near the necrotic area or the pancreas, so it's going to drain out the pancreatic fluid. But in your practice, before endoscopy, how many patients you really needed to go in and do a pancreatic duct stenting for those, before endoscopic era? Amit sir.
Pancreatic duct stenting?
Yeah, for post necrosectomy, pancreatic fistula, how many patients really needed intervention for those? Before endoscopic era. We talk of this in a debate many a times that endoscopy has advantage of reducing pancreatic fistula. I agree to that. But the patient lives with the drain for 3 to 4 weeks maximum, and over a period of time the drain output decreases and we remove the drain. That's a natural course of necrosectomy.
So how many patients require endoscopic
stenting post-surgical necrosectomy?
Post-necrosectomy leaks, correct?
Yeah.
Persistent leakage
of
the pancreatic juice.
Yeah.
That completely depends upon the threshold of the surgeon as well as the patient.
Yeah.
Some surgeons, some patients become very impatient. That no, this has to stop, this has to stop.
Okay.
Even if it is just 10 cc.
Yeah.
And then they force the endoscopist to do a ERCP and put a stent, but we try to avoid it as much as possible.
Agree.
But we should, the longer we wait, most of these leaks stop.
Most of these leaks stop. So,
and I think I agree with Amit in terms of the need to do pancreatic duct stenting in order to control this fistula. The success rate is very low, and the procedure is redundant most of the time because they are peripheral fistulas and they
are
don't
mostly in the
stop
tail.
very easily.
Yeah. So the best approach would be just to wait and watch, counsel the patient properly, put a stoma bag around the drain, and
many times it's the disconnected duct. Such type of leaks, you do a ERCP and you don't find any contrast going to the leak.
Understood.
So there's some duct inside which is near the tail of the pancreas which is leaking. Some parenchymal tissue which is disconnected from the main.
Okay. So this is a very good algorithm for all of us to understand. So if there is no infection, we just observe. If there is an infection and we have a good transgastric window, then endoscopic transluminal drainage. If patient has improvement, just observe. If there is no improvement and the muck is very thick, you go in and do a transluminal necrosectomy for these patients. If there is no transgastric window, if it's a paracolic gutter collection, then a percutaneous drainage. If there is no improvement, based on the location, you do ward or you do per-abdominal or percutaneous transperitoneal necrosectomy. Tome sir, what about open necrosectomy? Are we in an era where we should really advise open necrosectomies, or should we try to do it as much as possible with least invasive techniques?
Present day, all these such patients will be coming to tertiary referral centers. And most of these step-up approaches are available at tertiary referral centers. So surgeons are less likely to be involved with open necrosectomy for such patients.
Agree. So what about this? This is something which we did last week. So there is collection everywhere. You see anterior to stomach, lesser sac, around the kidney. Even as we come down, the collection is trickling into the right side. So what would be the ideal approach for such patients? Tackling these with...
Such patient is with general surgeons, most of the time they would undertake any laparotomy and drain all the collections.
Okay.
If such patient come to a tertiary referral centers, there will be interventional radiologists who might put 2 or 3 drains and drain out the collection. There might be a gastroenterologist who would be interested in giving antibiotics and manage conservatively such patients.
Amit sir, sometimes we have collection which is anterior to stomach, between the lesser left lobe and stomach. It's compressing the stomach anteriorly and a large collection in that. So putting a metal stent even through that is advisable or agreeable? How? Okay.
Never. We don't put a metal stent in that direction.
Okay.
So such collection should be drained either percutaneously or by minimal access surgery, by lap.
So this is one more CT, just your opinion on this. How can we tackle these collections? So you see this is a large lesser sac 1, and as we come down, we have collection going in both paracolic gutter regions as well as some amount of gas in that.
So it's a combination. You have to do a combination of all modalities.
So this is something which is hybrid.
Plus percutaneous.
Yeah.
Then you can manage these patients well.
Agree. So this is something in which you have to use a hybrid approach where you are taking care of collection in the lesser sac with an endoscopic approach and the paracolic gutters with the. So that's all we discussed different scenarios where we manage peripancreatic collections. I thank the panelist for this. Thank you. Yeah. Yes, sir.
Yeah, actually, in a recent review, which is presented on the endoscopic management, has not only shown benefit in the reduction of pancreatic fistula. This is a multicentric US data over more than, I think, 5,000 patients. The hazards ratio with endoscopy is only 0.27 as compared to surgery, and the percutaneous hazards ratio is 0.49. So it helps in reducing mortality, reducing hospital stay, and reducing the cost of the procedure. So endoscopic approach has to be given preference whenever it is feasible.
Yeah, of course, if it's...
Second comment is about the, as Amit said, we started putting percutaneously the self-expanding esophageal metal stent, and that we are almost done in about 8 to 10 of our patients. So it helps in putting the endoscope through percutaneous way, so hybrid way, and taking out the necrosis.
So what is the advantage of percutaneous endoscopic necrosectomy over the walled which we do laparoscopically? What is the distinct advantage of that? In fact, it's a bit costly, I feel.
Almost same. Approach is almost the same.
Yeah.
As far as you go retroperitoneal. If you go retroperitoneal, the procedure, even though it appears big, the patient is smiling and talking to you while you are doing the procedure. It virtually is a pain-free procedure. Okay. And you are doing necrosectomy in the retroperitoneum.
Okay. So only
wonderful procedure.
Change is the general anesthesia which we might be needing.
Yes.
And
just mild sedation.
It can be done in mild sedation.
Yes.
Okay. Right.
I think it's a interleukin which are liberated, and less is the intervention, less would be the interleukins which are liberated. So that makes a difference.
So Yogesh, if you don't mind, see wonderful cases you have shown and discussed. What is important is to realize even 2-3 cases we could have gone on discussing the pros and cons.
Yeah.
Because acute pancreatitis management is not a right or wrong, straightforward decision making that we have done this and it has turned out well. Because it's a very complex decision making process which has to be a multidisciplinary process. And the mere fact that one case we get it right or we get it wrong does not make it that that's the method to adopt. Also, we have to remember that all these newer modalities are also related to the expertise which is available. And you need to tailor this approach based on the expertise available locally, rather than always say that, endoscopic is better over this, and therefore we have to strive to do it endoscopically. As long as if you have the facility and wherewithal, it is fine. And I want to finally make a comment about open necrosectomy, that I don't think it is a dead and buried procedure, as many would want to make people believe. Because eventually we are still going to have to resort to open necrosectomy in some of that last type of patient that you saw.
Yeah.
And the cost and the duration of treatment in terms of multiple interventions vis-a-vis a single time good intervention at the appropriate time. So I just want to reiterate that. I mean, all this panel, I'm sure, would second that this is a very complex decision making which requires interdisciplinary interaction and taking a decision in each patient what is best for them.
That's why we have a team of IR surgeons as well as medical gastroenterologists giving the opinion on those cases. So that's how it has to be done. That's what we wanted to focus. Thank you. We will proceed with our next talk. The next talk is on biliary pancreatitis. Dr. Amit Maydeo sir is going to speak on that, and our chairpersons are Dr. Unmesh Chandak, Dr. Vikas Jain sir, and please. Abhijit Deshmukh sir. Yeah, third chairpersons for the session, Abhijit Deshmukh.
Good morning. At the outset, as chairpersons, I thank Bhandarkar sir and Yogesh for giving us this opportunity. So next in line is an important topic which is close to every surgeon's heart. And to talk on evaluation and treatment of biliary pancreatitis, we have a surgeon amongst us who is himself a legend in the field of endoscopic gastroenterology. I invite Dr. Amit Maydeo sir.
That's okay. That's okay. So thank you so much. So this is a very, very short presentation. I've summed the whole thing up in very few slides. But let me tell you, I've made a lot of statements in these slides, and each statement is backed by a lot of evidence, a lot of literature. I did a lot of study while preparing this lecture. So even though it is a short lecture, each statement which I'm making has got some significance. So let's start. So give you a little background. 70% of acute pancreatitis is because of alcohol or gallstones, and 40% in the Western world is because of gallstones. And in those patients who have gallbladder stones, there is a 7% risk of developing pancreatitis as you follow up these patients in the long term. Now, why does biliary pancreatitis occur? There are various hypotheses or mechanisms. First is, of course, a temporary obstruction at the pancreatico-biliary junction because of a stone, actually, which is impacted there. Second is just ampullary edema. Third can be stone has passed out, which has caused some local inflammation of that area. Next, transient reflux of bile inside the pancreatic duct, which causes the pancreatitis. And as was already told to us by Dr. Shrikant Mukhewar, small stones are more dangerous than single large stones or solitary big stones. So small stones are much more dangerous. First of all, you have to make sure that this is definitely acute pancreatitis when the patient presents. So patient has to fit in all the criteria of acute pancreatitis, and like any other pancreatitis, you have to stratify it, whether it is mild, moderate or severe according to the Atlanta classification. Most of the times in biliary pancreatitis, fortunately, this is a mild pancreatitis or interstitial pancreatitis. Very few percentage of patients develop severe necrotizing pancreatitis. Now, what are the factors which indicate that it is biliary pancreatitis? We have very strong factors and moderate factors. Strong factors is what? You can actually see a stone in the bile duct on imaging. There is acute cholangitis and bilirubin is more than 4. These are all factors which are directly telling you, yes, this is definitely gallstone pancreatitis. Strong is what? Just a dilated CBD you can see. You can't see any stone. And bilirubin is less than 4, but above 1.8 or 2. And moderate is just patient is an old age. You see here just deranged liver enzymes of possibly biliary pancreatitis. So what do we do? So any patient of biliary pancreatitis first has to be managed like acute pancreatitis. So you don't directly go after the bile duct. That we have to do. But first and foremost is initial management, which was already told to us. Patient should obviously be triaged and resuscitated in the initial stage. ICU is required only if there are criteria of SIRS. IV fluids from whatever criteria you follow, but most of the times we give IV fluids depending upon the requirement of ringer lactate, 120 to 150 to 180 ml per hour. And the aim, like any other pancreatitis, should be to initiate early enteral feeds. We definitely don't like TPN. Some form of enteral feeds have to be started, either a nasogastric or a nasojejunal tube. Routine antibiotics is not recommended. Even the patient has cholangitis, it's not necessary to many patients, many doctors, sometimes they start directly on meropenem. As soon as a patient comes with acute pancreatitis, you start meropenem, which obviously should never ever be done. Now what is necessary is, you have to do imaging studies. If you are suspecting biliary pancreatitis, very, very important. And in imaging studies, the simple screening tool is ultrasound, which will tell you about gallstones. Gallbladder stones are there or not there, but it is not a very accurate technique to find out CBD stones, because you are likely to miss bile duct stones because of the gas. Lower CBD may not be able to, you can see from transabdominal ultrasound. So the crux of the investigation here is endoscopic sonography. From the time US has been launched, any time you suspect a patient of biliary pancreatitis, EUS becomes the most mandatory investigation. So what you have to do is, EUS has a very high sensitivity of pickup of CBD stones or obstruction of the CBD. Specificity, sensitivity, both are high, and especially for stones which are lesser than 6 mm, it is better than even MRCP. Why do we do EUS? Because you can avoid a negative ERCP in almost 2/3 of the patients. Previously, we used to have a thinking that anytime you have a patient of suspected biliary pancreatitis, do an emergency ERCP, cut open the ampulla of Vater. Many times we used to find there was no stone. Stone had passed out, because we did not have accurate methods to know whether there is really a stone in the CBD or no. And one more thing I'll tell you. One of the indications of intervention in biliary pancreatitis is cholangitis. Now, cholangitis is a term which is very difficult to define. Now, why, whether there is really infection in the CBD or there is a fever because of some other reason, how much is the bilirubin raised? So, cholangitis is not a very definitive terminology. So, only on that you cannot base a treatment like an emergency ERCP. So, what is the role of ERCP in biliary pancreatitis? See, we all have to understand that in spite of all the skill that endoscopists have, ERCP is still a complex and a technically demanding procedure. And ERCP itself can cause complications. So, unsuccessful ERCP if you do, there is an unfavorable progression of the acute biliary pancreatitis. So, do your ERCP only if it is necessary. So, indicate it only if there is acute biliary pancreatitis with concomitant acute cholangitis, should be performed by a very skilled endoscopist, and if at all you have to do, it should be done soon, within 24 to 72 hours. But definitely no ERCP if there is no sign of CBD obstruction or cholangitis. So, the conclusion here is early ERCP should be done within 24 to 72 hours only if there is sufficient evidence of CBD obstruction on imaging as well as on biochemistry. So, what do? You have a patient of acute biliary pancreatitis which is suspected, treat like acute pancreatitis, do immediate imaging studies. If you don't have EUS, at least do an MRCP, which will give you some indication. And if all things are going in favor that yes, bilirubin is raised, there is a possibility of CBD obstruction, only then you should proceed with a ERCP. So what do we do when we talk about ERCP for acute biliary pancreatitis? Here you can see stone impacted at the ampulla of Vater. Quite simple. In an emergency, you go in and cut open the ampulla of Vater, almost like opening up a fruit, and you see here you can deliver the stone out by slight extension of this incision at the apex. And if this indication is perfectly selected, if there is really a stone there, you can really reverse the patient's deteriorating condition. Or you can see in such a situation, where you can actually see the stone which is popping out of the ampulla obvator. And this is one of the easiest ways of doing ERCP because you can't cut anything else. And what you're cutting is the bile duct, and you can see the type of bile which is coming out because this patient was in severe cholangitis. And here, in fact, you can see it's almost like delivering a child. Here you can't see the stone, the ampulla is closed. So by using a different type of a needle knife, different type of a pre-cut knife, we are cutting the ampulla from the orifice upwards towards the direction of the bile duct. And then we keep on extending this cut slowly. And after we extend the cut slightly, then what we do is take the same knife and push the stone out from below. And this way you can completely relieve the obstruction. Well, this is what is done after you have done a proper timed ERCP and after you have confirmed that there is CBD obstruction and cholangitis. Next is, when do we do a laparoscopic cholecystectomy in these patients of acute biliary pancreatitis? Now, there are sufficient guidelines to tell us that laparoscopic cholecystectomy should be done during the index admission itself if it is a mild acute biliary pancreatitis, and it should be a delayed lap chole if it is a severe acute biliary pancreatitis. So, clear-cut guidelines. So, the so-called condom of acute biliary pancreatitis, you can divide it into steps. After the patient comes, do an imaging, confirm if there is a very strong indication, very strong possibility of CBD obstruction, early ERCP. That is the best way you can prevent progression of the disease or avoid unnecessary ERCP. And afterwards, you can time the laparoscopic cholecystectomy depending upon the type of pancreatitis, whether it is mild or it is severe. That's all. Very simple presentation. Thank you.
Really, sir, very simple presentation and very clear. Thank you, sir.
Questions from audience?
Any questions?
Any questions? No.
Sir, a lot of times there is pancreatitis. The bilirubin is what you said, less than say just 2, 1.5. There is no obvious evidence of obstruction of the biliary tree, but you find stones in the CBD. So, what is the right time to go in for an ERCP? If the patient has come to you within 24 to 72 hours, there is no patient is stable, not much pain, and there is no obstruction. You would like to do the ERCP in the initial?
If you actually find stones in the CBD, ERCP is indicated. Even if the stone is not impacted at the ampulla obvator, because temporarily that stone must have gone back. But if you don't find stones in the CBD, if there is just pancreatic edema and surrounding inflammation, no indication of ERCP. Even though there is mild raise of bilirubin, that mild raise of bilirubin could be purely because of the pancreatic edema and extrinsic compression of the bile duct. So, manage conservatively, patient will recover.
Another follow-up question on the same case. If you think that the stone in CBD is large, sir, you do like to do a sphincteroplasty in that setting and or just put in a stent? And
No. Only relieve the obstruction, just put in a stent, drain the obstruction and come out.
Sir, just the
no adventure.
Extension of this question only. What are the stones which are not amicable to ERCP according to you? I mean, the CBD stones in biliary pancreatitis, which you will refer to a laparoscopic or some surgical intervention.
In biliary pancreatitis, what CBD stones are not?
Amicable to ERCP, I mean, you will not be able to remove those
Nothing
stones
like
or
that.
indication for
Nothing like
laparoscopic
that.
or
In today's scenario, we can remove almost all CBD stones.
That's what I wanted to ask.
No,
What are the other, I mean,
nearly 100% success.
What are the modalities, I mean, you use for larger stones, I mean, the big
everything.
impacted stones in CBD?
Everything we can do. We can do a wide sphincterotomy, we can do a sphincteroplasty, we can do a cholangioscopy with laser, even for a Mirizi syndrome, for intrahepatic stones,
Yes,
for
that's
everything.
what I wanted to ask. Okay. Thank
So we have got so many, and nowadays what we do is we have started using the thulium laser, not even holmium, where the stone gets dusted. And if all that fails, then we do ESWL. We put a nasobiliary catheter and do shockwave lithotripsy.
Sir, one more question.
Sir, few of the patient we see, sir, from chair.
From that side.
Yes.
Question
Yes,
from
sorry,
that side.
sorry.
Yeah. So some of the patient we see, the patient with acute cholecystitis, but no stone in CBD and the bilirubin is rising around 2.5. And USG or other modalities also doesn't shows any stone in the CBD, but we was suspecting. So in such case, what to do? Means microlithiasis or something
No,
like.
microlithiasis will not cause bilirubin to rise. Microlithiasis will only cause pancreatitis, but it will not obstruct the CBD and cause bilirubin to rise. In acute cholecystitis, if your bilirubin is rising and if you don't find a stone in the CBD, it could be because of peri-gallbladder edema, which also causes edema around the bile duct, and that can sometimes cause mild raise of bilirubin. So you can directly proceed with the lab chole. I think the bilirubin will reduce. What do you think, Sadiq?
Okay. And the patient with acute cholecystitis with pancreatitis, where the no stones are there in CBD, how to proceed in such cases, sir?
Do nothing. Treat the pancreatitis with conservative measures.
Or treat the lab
treat the
chole.
cholecystitis also with conservative measures.
Okay.
If the cholecystitis is not coming under control with conservative measures, and the pancreatitis is also severe, then don't try to do a lap chole, do a cholecystostomy.
Sir, do you always put a stent, I mean, in biliary pancreatitis before laparoscopic cholecystectomy?
Stent?
Yeah, CBD stenting.
We usually do. Because the fact that this stone has come down from the gallbladder, new stones can also come down. So we protect the CBD by putting in a stent temporarily, which we can take 1 month out later after the cholecystectomy.
Thank you, Dr. Amit, for a fantastic
Thank you.
talk showcasing the art and science of biliary pancreatitis. And thank you, chairpersons, Dr. Vikas Jain, Dr. Unmesh Chandey, and Dr. Abhijit Deshmukh. The next two very short sessions are video sessions. First is minimally invasive necrosectomy by Dr. Prashant Rahate, and the chairpersons are we have got two deans in this session as chairperson, Dr. Raj Gajbi and Dr. Girish Jatkar, and Dr. Mukund Thakur also. Who could have been the dean?
Yeah, it was a pleasure to be here. I am regular.
So my home batsmen, I can ask them to score very quick runs. And get a big applause from everyone.
I was regularly visiting Dr. Amit since 1990 from Tibhatia Hospital to Baldota, and it is pleasure to be here with him. So minimal invasive pancreatic necrosectomy, my respected moderators, and all the questions have already been answered. When to intervene, timing, what is the reason to intervene, how to intervene. That is the clinical condition of the patient, local experience and expertise is very important, because we are not always in the tertiary care center, but even at the periphery, local experience and expertise will decide. And the anatomical position of the collection and the content of the collection, that depends regarding the type of intervention you are going to do. The time of presentation before 4 weeks and after 4 weeks, whether it is matured wall or not. So all these things, they have been discussed. So the approaches are the transgastric and the transcolic, or through the lesser curvature, into the lesser sac, or the retroperitoneal, that is ward, which we have discussed. So the questions are when to intervene, timing reason already. Then what is the second go? That has not been discussed. The two procedures simultaneously, endoscopic and the laparoscopic or IR, that can be simultaneously done. And disconnected duct syndrome, if it is there, and the pancreatic ascites. So all that can be managed by minimal invasive. And whether the patient needs multiple interventions, that is also a question, and we have to give a clear idea to the patient and relative that the multiple interventions are
Prashant, can you raise your mic, straighten your mic?
Multiple interventions are the rule in this particular scenario. And we should also discuss the various complications, what are the immediate complications and delayed complications. we are not going to discuss about this particular, many of us are doing this, the laparoscopic cystogastrostomy. The posterior wall is tackled, and how that is done, many of us know. So we will not discuss that. We will be focusing on ward. So this is video-assisted drainage, retroperitoneal drainage is ward, and we will see the video here. A very large collection right from the epigastrium, the upper abdomen, to the lower abdomen up to the pelvis, with a lot of retroperitoneal debris there. So right up to the pelvis. So this particular patient, we'll start the video again. So that particular collection was mostly on the left side, displacing the spleen, the stomach, and everything. The collection was, patient was symptomatic, high-grade fever, non-responder to the antibiotic therapy. Even the antifungals were also there. This particular patient had scrub typhus, and post-scrub typhus, he had severe pancreatitis. So we went in by putting a laparoscopic port under sonographic guidance, and then put second and third operative ports inside. Even a 20 mm port can also be inserted directly, so that large necrosum can be removed. So almost 4 liters of fluid was drained, and after that we had to go in. The pneumo was created, which was up to 10 pressure with very slow flow, because retroperitoneum is vascular, and that can lead to embolization, or even the septic foci can get embolization. So it is low pressure with low flow, that is the rule. And this mug, which is very sticky and difficult to remove, as Dr. Amit Maydeo has said, there is no proper instrument available. And same is the story with the laparoscopic thing. No proper instrument is available. So endo bag we can put bit by bit, very sticky, and every time you have to clean the jaw of the instrument, because it stucks up to the jaw. So I will try to fast forward this thing. So while removing this mug, we have to take care that we don't want any vascular complication there, because lot of vessels, they are running in the retroperitoneum, and we are lifting the retroperitoneum by CO2, and if we are having a bigger aperture or bigger incision is given laterally, then you have to insert a Dever's forceps, Dever's retractor, and that can tear off the IVC either on right side, or it can tear off the smaller vessels from the aorta on the left side. So I will try to fast forward. So all this mug is removed. At the end of the our motto, the purpose of removing this particular mug, as possible, it should be removed, because we are not going to be very aggressive in the first go, because there are very high chances of the vascular catastrophe being caused. Most of the vessels, they are either thrombosed, and because of your pulling and traction, the vessels might get torn off, and large endo bag such as zero bag can be inserted, and the complete mug can be removed. So after the mug is removed, and if the patient is stable, you can go ahead and do more necrosectomy. But if the patient is unstable, then we can pack the cavity and come back on second or third day. So here the patient was packed, the posterior cavity was packed. We removed the packs on third day by giving the extension of the 3 ports were done and packing was done. And we can insert, in such cases, a big size Devers retractor and do a second look necrosectomy. So, gradual and very patient thing is very important, because removing these particular foreign bodies or packs, that can also give rise to some problem over the vessel tractions. And then we can insert a laparoscope inside to examine and do a proper necrosectomy, which was not done before, so that vessels can also be identified and you can identify the granulation tissue which is started doing. And we can keep 2 drains, keep on irrigating 10 liters for 24 hours almost for the next few days, and then gradually we can see whether there is a pancreatic fistula, whether any duct disconnection, or whether any new world of necrosis is being created. So serial ultrasonography is needed. You can see now the granulation tissue has started growing, and you can see the vessels down here. So that is how the posterior ward treatment that is advisable. So we have to declare to the patient that there can be mortality, postoperative morbidity, there can be hemorrhage, pancreatic fistula can be there, intra-abdominal infections can be there, enterocutaneous fistula, which is also one of the very problematic condition, and additional percutaneous drainage might also be needed. The postoperative hospital stay might prolong, and recurrent one and repeated surgeries will be needed. And new onset diabetes is also one of the. Then pancreatic exocrine insufficiency is also you have to manage. So vascular complications, the arterial and venous, you have to deal with. You have to inform the IR people while you are doing this, or you can always be ready with the open method. So thanks a lot. Thanks VSA and thanks DDS for giving me this opportunity. Thank you.
Well, excellent presentation, Prashant. Nice video. And this approach seems to be very good, where the necrosum or the collection is pointing very close to the abdominal wall. But there are certain collections which do not come closer to the abdominal wall. So here you could take a large incision and do a relook scopy to clear the cavity. But sometimes the collection could be a little bit deeper, wherein you, as it was suggested earlier, you create a track and then introduce scope, either endoscope or you can use a nephroscope. Nephroscope is
so
a
that is
wonderful
sinus tract debridement or necrosectomy.
Yes, that gives us a channel for irrigation as well as a crocodile forceps for removal of the necrosum. So wonderful approach, and thanks for a wonderful video.
Thank you so much. Thank you.
Wonderful video. Horrifying for newcomers.
Thank you.
Thank you, Prashant, for a nice video presentation. I thank the chairpersons, Dr. Girish Jatkar, Dr. Raj Gajbi, and Dr. Mukund Thakur. Please be seated for the next video also. I request Dr. Siddharth Dande to join me for presentation by Dr. Manoj Veware. He'll be showing a short video on percutaneous endoscopic necrosectomy.
So, good morning everyone. At the outset, I would like to thank the team DDS and VSA for giving me this opportunity. As we have already discussed that the multidisciplinary minimally invasive step-up approach plays an important part in management of infected pancreatic necrosis. And as Dr. Ahate sir has shown about the surgical interventions, I will like to introduce our direct endoscopic necrosectomy, which is another very minimally invasive intervention in management of infected pancreatic necrosis. So how we do approach for this endoscopic necrosectomy? There are two approaches. One is transmural direct endoscopic necrosectomy, which is the most preferable one approach. And the first initial step, as we already discussed, is a US guided lumen opposing stent, metal stent placement. The another approach, what we are discussing, is the percutaneous approach, when the transmural drainage is not possible and you have got a conventional drain in situ by the virtue of either percutaneous or the surgical intervention, whichever is done earlier. So I will go through a video of initial step of transmural endoscopic drainage. So this is a US guided lamps placement. This is a large wall of pancreatic necrosis which was symptomatic. So before a 19 gauge needle punches this collection, we scan the area with a Doppler to look for whether any intervention or intervening vessel in between. The fluid is aspirated for bacterial studies, and then the guide wire is, the 035 guide wire is passed within the cyst so that it makes at least 2 coils within that cyst. So this is a guide wire almost going inside, and then this tract is further dilated with a 6-French cystotome before placing the lumen opposing metal stent. So this is a lumen opposing metal stent with a distal flange of the lumen opposing metal stent, which is then released, and then it is pulled, the entire assembly is pulled up so that it opposes against the wall of pancreatic necrosis, and then the proximal flange of the lamps is released within the channel of the US scope. And once it is released, slowly you push out that proximal flange out of the scope, out of the channel, while distancing the distal end of the US scope away from the gastric wall. And this is how you place the lamps. This is a biplane stent. You have got one end in the stomach cavity and another flange in the gastric, in the one cavity, and this is a wonderful fluid which is draining up. So this is a double pictet which you usually place so to prevent the dysfunctioning of the stent because of the clogging by the necrotic debris. So that already discussed what's the step-up approach for this post-lamps placement, because if you follow the post-lamp statement step-up approach, then only 10 to 11% of the patients need necrosectomy. Not all the patients require necrosectomy. So first step is declogging of the lamps. If no response, then you put an nasocystic drain and irrigate the cavity, and if no response, then you consider to go ahead with the direct endoscopic necrosectomy. So this is how we do it. The most important step in direct endoscopic necrosectomy is to irrigate the wound cavity so that evacuation of the pus and everything gets very easy. And the important part is to only remove the loose debris with a gentle traction. The adherent debris has not to be removed because they will create more and more complications. The accessories for us, because the channel is very small, we have got a very small accessories for doing the endoscopic necrosectomy. And the end point of the direct endoscopic necrosectomy is a clinical improvement along with the near complete removal of the infected necrotic debris and visualization of the healthy granulation tissue along with the cavity of the wall. Usually what we have discussed earlier, usually it's a 2 to 3 sessions of the necrosectomy that are needed to clear the wound cavity. The another approach which is there is percutaneous endoscopic necrosectomy, which is another form of a minimally invasive technique, which is called as sinus tract endoscopy also, and where you have a collection which is in the paracolic gutter or the pelvis, where the transmural approach is not possible, or the cyst wall and the gastric wall is away more than 1 centimeter, or the patient is having severe coagulopathy. So where you need a percutaneous drainage initially. So what are the steps involved in the percutaneous endoscopic necrosectomy is, you first put a percutaneous drain, which is mostly by the intervention radiologist, and this helps to reduce the source of infection. Secondly, it helps to stabilize an ill patient, and also it helps to allow the wall to wall off. So this track usually takes about 7 to 10 days to mature, And once this tract is matured, then one can consider to do the necrosectomy. So before the tract, for doing the necrosectomy, you have to dilate the tract for passing your upper GI endoscope of the flexible endoscope. And for this dilatation of tract, if the tract is very short, about 3 to 4 centimeter, which is very close to the skin, then you can just do the dilatation by the CRE balloon. And if this tract is very long, about more than 5 centimeter, then the balloon is usually not very helpful. Then these tracts can be dilated easily with the nephrodilators as compared to our usual routine Savary-Gillard dilators, because this nephrodilators has got very short nose. Or the other instrument, what Dr. Amit Maydeo sir has discussed, what putting a fully covered esophageal metal stents within this tract so that the long tracts get dilated. And if you have the need of a frequent dilatations in such situations, the fully covered metal stent helps you by placing it at once. So you go ahead with the necrosectomy through the stent or the tract dilated. And then after the session of the necrosectomy, it is preferable to put a large pore drain and irrigation catheter so that the subsequent necrosectomy, the tract is kept dilated for the subsequent necrosectomies. So this was just a case. The patient presented to us in a 6th to 7th week of the infected walled up pancreatic necrosis post-surgical intervention. So this was a long tract. This was a drainage catheter, surgical drainage catheter, and this was a very residual infected necrotic material, and the tract was very long, about 7 to 8 centimeter long. And so that's why we decided to go ahead with the stent-assisted percutaneous direct endoscopic necrosectomy. We put the guide wire through the abdominal drain, and then the catheter was placed so that the bone cavity is delineated with the contrast. After delineation of the bone cavity, we dilated the tract further with these amplased nephrodilators. This is a short nose of the dilators, and then the fully covered esophageal metal stent was placed for the tract dilatation. And this was the outer end of the stent which was secured to skin, and this was the inner end of the stent which was within the bone cavity. We initially placed a 7 French irrigation catheter to irrigate the cavity so that the entire irrigated material gets collected outside in the stoma bag. So this was the stoma bag which was collected, and the continuous irrigation was done. 2 days later, we planned for endoscopic necrosectomy through the stent, and this is how the stent goes through it. And you can see the lot of necrotic debris within the bone cavity. Lot of necrotic debris, and what we usually do with our small accessories, right tooth forceps, then baskets, roth nets, everything helps to remove this necrotic debris. And this is what, after the two sessions of the endoscopic necrosectomy, we can have a very clean cavity with a clinical improvement in the patient. The beauty of the flexible endoscopy is that we can reach deep within various extensions in the abdominal cavity because of its flexibility and versatility, and this is how you can just go ahead with direction whatever you want to do. After 1 week, we removed the stent and put a drain, and then gradually we downsize that stent over every weekly so that the tract gets closed. Thank you very much.
Very nice demonstration, Manoj, of both transmural and percutaneous endoscopic approaches. Just one quick question. We hear a lot about that lamps should not be placed for a very long time because of fear of bleeding. So can you exactly
So
outline
usually the
risk?
lamps should not be more than 4 weeks nowadays, whatever the recommendations are there, because the complications are much more higher, because the whatever the inner end, the flange is there, that tries to erode the cavity wall, and so the bleeding risks are on the higher side when the lamps is placed for more than 4 weeks. So it has to be removed before the 4 weeks nowadays.
So the double pigtail prevents that complication completely or to some extent?
No, double pigtail prevents that complication almost completely.
Any? Sir, one more question. What should be the frequency interval between 2 necrosectomy sessions ideally?
So usually we do at least after 2 to 3 days first session and then wait for at least 48 hours, and then if it is need of a necrosectomy, then go ahead with that one. Usually 2 to 3 days is the one which we prefer for necrosectomy sessions.
Okay. Thank you so much,
Thank you, sir.
once
Thank
again.
you.
Thank you once again, Dr. Raj, Dr. Mukund, and Dr. Girish Chatkar, sir, and Dr. Siddharth Dhande. Already curtailed inaugural function of 10 minutes, I further reduced to 8 minutes. Just a very, very brief background how this conference was conceived. Actually, almost 6 to 8 months back, this theme was conceived by Dr. Yogesh Bang, and he has single-handedly not only conceived the theme, he planned the entire details and executed. So each delegate who is present here today in the hall is thanks to all his efforts. So it's done a really Herculean task. I have served as a ceremonial rubber stamp to everything, including the panel discussion I participated in. So and his meticulous approach to the whole theme-based conference, you must have seen in his his panel discussion, which he moderated so well. So thank you, Yogesh. This conference is all your show. And of course, then we had the backing of the two societies. I mean, the backing was the first thing we got, and then we proceeded. So DDS, led by the Shahanshah of gastroenterology in not only in Nagpur and central India, but the entire India, Dr. Shrikant Mukhewar, his blessings and his strong backing to every activity, whether it's a small one or a big one, it is his own personal Midas activity or any other activity taken up by anyone. He's always been a rock pillar support to all of us. So with that, and of course the VSA President Dr. Girish Jatkar and VSA Secretary Dr. Nirmal Patle, they have extended their unconditional support all the time, encouraging Yogesh and also helping him out in planning the other details of the conference. And my secretary, DDS Secretary Vaibhav Anait is here. So he also has done a lot of efforts for making its conference a success. With that, I request the dignitaries, Dr. Maydeo, Dr. Sadiq Sikora, Dr. Rupjyoti Talukdar, Dr. Raj Gajbhie, and Dr. Dasgupta sir. I acknowledge his presence, and Dr. Raj Gajbhie, Dr. Girish Jatkar sir, and Dr. Shrikant Mukhewar to come up and light the Samai, which will mark the symbolic inauguration of this small half-day single-theme conference on pancreas. Yes.
Asato ma sadgamaya, tamaso ma jyotirgamaya, mrityurma amritam gamaya. Asato ma sadgamaya, tamaso ma jyotirgamaya, mrityurma amritam gamaya. Asato ma sadgamaya, tamaso ma jyotirgamaya, mrityurma amritam gamaya. Asato ma sadgamaya, tamaso ma jyotirgamaya, mrityurma amritam.
Another very, very brief but pleasant task is felicitation of our guest speakers. So I request Dr. B.S. Gedam, Senior Surgeon, sir. Gedam, sir, right? Gelik. Okay. Dr. B.S. Gedam has been a teacher for almost 98% of the surgeons present in this hall. I request him to felicitate Dr. Amit Maydeo and thank you, Dr. Gedam. May I request Dr. Siddharth Dubashi, the Professor and HOD, All India Institute of Medical Sciences, Nagpur, to felicitate Dr. Sadiq Sikora. On the PPT, you can see the very, very brief biodata. You will understand why it is. So the brief has got two meanings, I guess. Thank you, Dr. Dubashi. Thank you, Dr. Sadiq. May I request our senior surgeon and ex-dean, Dr. Das Gupta, to felicitate Dr. Rupjyoti Talukdar. Thank you, Dr. Das Gupta. Thank you, Dr. Rupjyoti. Two people who we thought we have a lot of right on them, and we take this opportunity and express our love and gratitude and respect for achieving the highest position that is academically possible in our country in medical college. And they are the deans. First I request Dr. Shrikant Mukhewar to felicitate Dr. Shrikant Jatkar, who recently took charge, Dr. Girish Jatkar, for recently has taken charge as the Dean of Yavatmal Medical College. Girish is like elder brother to us, and it's a very, very proud feeling that he remains as humble and as down to earth as I know him as 2 years my senior. Thank you, Girish. Thank you, Dr. Mukhewar. I request Dr. Brijesh Gupta to felicitate Dr. Raj Gajbia, a very dear friend and a very big patron of all the academic activity that goes on in this city, especially related to gastroenterology. And everybody recognizes his hard work in bringing up the Department of Surgery in Medical College. Thank you, Dr. Brijesh Gupta. Thank you, Dr. Raj. Before Yogesh proceeds with his word of thanks, I would like to request Dr. Shrikant Mukhewar to quickly address this gathering and give us some guidance for future also.
Thanks, friends, for giving this opportunity. Prashant, I must say that he's always has a very expressive, kind words for me. So I always have a good bond with him. I must tell you that a lot of hard work was done by Dr. Abhiram Paranjpe in registering this society. And apart from clinical meetings, I feel that there are so many young gastroenterologists who have come. So we should be expanding into many more areas and having more activities of the society. That is my desire. And to tell you, because of young people joining the scene of gastroenterology in the field of gastroenterology in the city of Nagpur, we are at par with most of the procedures. We are at par. The only problem with us is we are not publishing our data. So that's why we have not been known about it. So we should start publishing our data so that we come to the forefront in the national scenario. Thank you so much.
Thank you, Dr. Shrikant, for those kind words. And few announcements for the two upcoming modules. One thing is we are slightly behind schedule, so if all the speakers can cut down 2 minutes of their presentation, we might save 10 to 15 minutes. But that's just a polite and humble request. There is no wish to force such illustrious faculty to wrap up their presentation at any cost. So just sincere request for cooperating. We may change the sequence a little bit because all the guest speakers have to catch their early flights between 3 and 3:30. So we owe to them that we make them free on time. And there won't be any formal vote of, there won't be any vote of thanks after the meet is over. So I request Dr. Yogesh Bang to propose a formal vote of thanks right now.
So I would like to thank my faculty who agreed to come up just on a single call. I remember calling up Dr. Talukdar sir and Sadiq sir, and they said yes in a single call. Even Amit sir said yes in a single call to Bhandarkar sir. Thanks to them. I thank senior members who always support us in these academic activities, Dr. Mukhewar sir, Jatkar sir, Gajbiye sir, Dr. Prahate sir, and of course the strong person standing behind me, Dr. Bhandarkar sir. I thank all the chairpersons who have come all the way from Vidarbha. All areas of Vidarbha surgeons have come up and gastroenterologists have come up. I thank them. The success of program cannot be without an excellent audience which is sitting here. I thank all the audience for sparing your Sunday with us. These events are not possible without support from the industry. I thank Sun Pharma people, Atul, Trilok, they have done an excellent job. Thank you for that. And support from Mr. Andulkar for this event. Thank you very much. I now we will now proceed with the next module, chronic pancreatitis. I request Dr. Amit Kavimandan to come up on the dais. The chairpersons for the session are Dr. Gupta sir, Brijesh Gupta sir, Dr. Lakshmikant Ladukar sir, Dr. Ravindra Telkar sir, and Dr. Vaibhav Banait sir. I request the chairpersons to occupy the chairs.
So Amit is our own stalwart from Amravati, is an alumni of the prestigious All India Institute of Medical Sciences. So he is batting again on his home pitch. Welcome, Amit.
Yeah. Thank you, sir. Good afternoon, everybody. First of all, I'd like to thank DDS and VSA for giving me this opportunity to be with you in such an august gathering. So we are talking about chronic pancreatitis now, and I'm going to talk about the etiological evaluation of chronic pancreatitis. I'll start with some cases. We all know what is chronic pancreatitis, but all the time we come across cases where we keep on thinking what would be the cause, and is the etiology important? Because yes, if you know the etiology, we can direct our therapies accordingly, and prognosis of that patient can be altered accordingly. So first case is a very simple case. He's a 45-year-old male who has history of alcohol use 3 to 4 days a week, more than 250 ml per day for 10 years, and he's also smoking. So there is no doubt what we are dealing with here right now. He has history of recurrent severe upper abdominal pain radiating to back, requiring repeated hospitalizations since past 3 years. He has occasional history of steatorrhea also. There is anorexia, weight loss. So just by this clinical history, we know that this patient has most likely a chronic pancreatitis, and the etiology is quite staring in our eyes. So there is no question. So we are looking at a alcohol-related chronic pancreatitis here. Next case is a 23-year-old male who has no history of alcohol use, smoking or tobacco, but he has history of recurrent severe upper abdominal pain radiating to back, requiring hospitalization for past 2 years, no steatorrhea, no anorexia, weight loss. An ultrasound during repeated admissions has shown there is bulky pancreas, and he has bilateral renal stones also. On lab investigations, he has elevated serum lipase during the hospitalization, and his serum calcium in between has also been elevated. And interval imaging without any episodes of pain has been normal. So again, here we are thinking either this could be recurrent acute pancreatitis or this could be underlying chronic pancreatitis. So is there a clue for etiology here? The clue for etiology could be bilateral renal stones, elevated serum calcium. Third is a young female, 8-year-old female who has presented to us with first episode of severe epigastric pain with vomiting for past 8 days. There is history of previous abdominal pain, but not requiring hospitalization. So the pain was not so severe. So whether we are not sure whether the previous episodes were pancreatitis or not, but she has a family history of chronic pancreatitis. Her distant cousin is suffering from chronic pancreatitis. There is elevated pancreas, and ultrasound abdomen has shown the pancreas is atrophic. So these are 3 kinds of chronic pancreatitis which we can get. So we are going to talk about how to evaluate such cases. So what is chronic pancreatitis that we know, and the new definition which has been proposed, it encompasses all the risk factors of chronic pancreatitis. What it says is a pathogenic fibroinflammatory syndrome of pancreas. There was a persistent pathological response to pancreatic parenchymal injury or stress in individuals with either genetic, environmental or other risk factors. So these 3 things are very important, that there are underlying risk factors, there is injury, and there is damage to the pancreatic parenchyma. These 3 things are important. So clinical features, clinical history is important, risk factor for chronic pancreatitis is important. We need to know what are the risk factors for developing chronic pancreatitis, and what imaging or biomarkers can be done to diagnose chronic pancreatitis. So what is the scenario of chronic pancreatitis in India? There was a multi-center study, the data from Dr. Mukhya sir's center was also there, published in 2008. It was a study in which there are more than 1,000 patients of chronic pancreatitis were evaluated. The most common cause of chronic pancreatitis in India was reported as idiopathic chronic pancreatitis. Almost 38% had alcohol related, and other causes were 1%. And that what we used to study in our textbook was tropical pancreatitis. Tropical pancreatitis was taught as pancreatitis in young adults who had severe diabetes mellitus, had multiple calcifications or stones. So this was typically presented from south of India and was supposed to be associated with cassava ingestion. But that tropical pancreatitis is not seen nowadays. And in this study also, only 4% of patients were able to put into that classification. And to significant point is that 30% of these patients had history of smoking, and prevalence of chronic pancreatitis, from another study it has been estimated that it has been one of the highest in all the Asian population, almost 125 in 10 lakh population. So how do we approach? Thorough clinical history is very important to diagnose the etiology of chronic pancreatitis. We must know the number and duration of pancreatitis episodes, whether patient has history of diabetes mellitus, there is any history of maldigestion or malnutrition, weight loss, and any abnormalities in the bone health. Also, family history must be taken, and up to 3rd degree relatives, because there are definite genetic evidence for chronic pancreatitis. Now what we were considering as idiopathic pancreatitis, even in India, now evidence is coming up that Dr. Rupjyoti sir is here, he is the master in this, that there is definite genetic evidence basis for idiopathic pancreatitis even in India. And when we take family history, we must not only ask about pancreatitis, we should ask about also diabetes mellitus and history of pancreatic cancer in the family. So any distant relatives also, if they had these problems in the family. So what are the risk factors? We looked at 3 points. One is clinical features, risk factors, and third is the imaging and biomarkers. So we look at the risk factors. The most important classification used for etiology and risk factors for chronic pancreatitis called as TIGAR-O. It is an acronym which involves toxic metabolic, idiopathic, genetic, then autoimmune, then recurrent acute pancreatitis, and obstructive. So what are the toxic metabolic risk factors for developing chronic pancreatitis? If we go back to our cases, the first risk factor was alcohol. So alcohol is a definite risk factor for chronic pancreatitis. What is the duration? What is the quantity? Any quantity of alcohol any duration of alcohol is a risk factor for chronic pancreatitis. There are multiple studies which have shown that any risk, duration and any dose is a risk factor, and the doses are lower in Asian population and also in women as compared to men. So the risk is exponential and it is dose dependent. Higher the dose, higher the duration, more is the risk. Also, smoking is a definite risk factor for development of chronic pancreatitis, and it is an independent risk factor apart from alcohol. It is not that smoking along with alcohol causes chronic pancreatitis. Smoking itself can cause chronic pancreatitis, and also it is dose dependent. Even lower doses can have risk of chronic pancreatitis, and again same thing, lower doses can cause problems in females also. Then we come to metabolic hypercalcemia. In patients who have hyperparathyroidism, if serum ionized calciums are more than 12 or 3 millimoles per liter, again it is a risk factor for chronic pancreatitis. That is because of hyperparathyroidism. Hypertriglyceridemia, if the triglycerides levels are more than 300 milligram per day, DL, fasting and non-fasting more than 500, again a risk factor for development of chronic pancreatitis. Other medications, then toxins, even CKD is known to develop chronic pancreatitis. Other metabolic, diabetes mellitus can also have sometimes histological features associated with chronic pancreatitis, but clinically whether diabetes mellitus itself causes chronic pancreatitis, that is not very clear. Then we come to idiopathic. Idiopathic, as we see in India, it is very common, and now evidence is coming that there is genetic background to this idiopathic chronic pancreatitis. And genetic, there are multiple genes which have been associated with development of chronic pancreatitis. The first gene which was detected was PRSS1 mutation. It is an autosomal dominant and it causes hereditary pancreatitis, and it was risky in the sense that it is high chances of development of pancreatic carcinoma. Other autosomal recessive genes are CFTR, that is cystic fibrosis genes, then SPINK1 gene. This SPINK1 gene is very important in India. Almost 40% of idiopathic pancreatitis patients in India have SPINK1 positive. Other complex genes are also there which are coming up. Then the next is autoimmune or steroid responsive pancreatitis. It is a different etiology altogether. It is of type 1 and type 2 that we'll discuss briefly. And then the question comes is recurrent acute pancreatitis and severe acute pancreatitis. There is always a question whether patient who has developed acute pancreatitis can go on to develop chronic pancreatitis. Studies have shown that patients who develop severe acute pancreatitis, 10% can go on to develop chronic pancreatitis, but usually it is more in patients who develop acute pancreatitis because of alcohol and smoking. So they can go on to develop chronic pancreatitis, and patients who have recurrent acute pancreatitis, the risk of development of chronic pancreatitis is almost 30 to 50%. Again, in patients who have either genetic predisposition or toxic exposure in alcohol and smoking. Other obstructive pathologies are pancreas divisum. Again, it's a controversial thing. Pancreas divisum is a very common morphological abnormality, but whether it itself causes acute pancreatitis or chronic pancreatitis, that is still open to discussion. Again, some people say that there is genetic background to development of chronic pancreatitis. Other things are main pancreatic duct stones, calcification, or tumors causing obstruction. So how do we diagnose? As we looked at 3 approaches. Clinical features, patients must have pancreatitis like pain, mild digestion, weight loss, may or may develop glucose intolerance. Plus, we must look at the risk factors, because any test has higher test probability if the clinical features and risk factors are there. You are not just going to do a test based on your assumptions. So we looked at the clinical features, then we looked at the risk factors according to the Tigaro classification. If they are there, then the first diagnosis is a cross-sectional imaging. We have suspected that this patient has chronic pancreatitis. He has risk factors for chronic pancreatitis. Basic investigation and ultrasound must have been done earlier, which may or may not give an indication. So next investigation would be a cross-sectional imaging. Cross-sectional imaging would be a good contrast enhanced CT scan or a good MRCP. That will give us the diagnosis in most of the cases. But if that is not able to give, the next step of investigation would be an endoscopic ultrasound for the diagnosis of chronic pancreatitis. And for the etiology, we have to go back again to the risk factors, whether alcohol or smoking is there. If they are not there, the next step would be metabolic, to look at the serum calcium, serum parathyroid, that is intact parathyroid, triglycerides. If three things are not there, the imaging does not show any obstructive lesion like pancreatic divisum or any tumor, then the next possibility is genetic or idiopathic. So, idiopathic or genetic we have to evaluate. And again, autoimmune pancreatitis, the imaging will give a characteristic morphology of a sausage shaped pancreas, in which there will be irregular dilatation of pancreatic duct without pre-stenotic dilatation. So, most of the time imaging can give us a diagnosis. To confirmation, we can use tests like IgG4, and there will be extra pancreatic diseases also, like autoimmune pancreatitis type 2 is associated with ulcerative colitis, or autoimmune pancreatitis 1 is associated with retroperitoneal fibrosis and other IgG4 diseases. The last step is, the gold standard is histology, but it is rarely required and rarely available. Again, the same thing this diagram is showing. So, I will touch upon idiopathic chronic pancreatitis in India, because it is supposed to be the commonest cause of chronic pancreatitis in India. Historically, idiopathic chronic pancreatitis in India was described as tropical calcific pancreatitis, typically reported from southern states of Kerala, in which it was described as young age patients developing chronic pancreatitis below 10 years of age. They would have diabetes in their second decade of life. On imaging, they will have lot of calcifications, lot of stones in the main pancreatic duct, and they will have aggressive course. By 20 to 30 years of age, most of these patients used to die either because of complications of diabetes or complications of chronic pancreatitis. But all this is changing. This was being reported in 60s, 70s, 80s. All this is changing. New evidence after 99 has come up that there is genetic basis for this idiopathic chronic pancreatitis. So, multiple studies from India have shown that SPINK1 mutation, 40% of patients with idiopathic chronic pancreatitis will have SPINK1 mutation. Then other mutations like CFTR, CLD2, MOR, C4, these are also there. And there is also changing phenotype of idiopathic chronic pancreatitis in India. We are not seeing patients who are younger in age, we are seeing patients who are in 30s and 40s. There is higher BMI. Earlier it was described that patients who are having idiopathic chronic pancreatitis will have malnutrition, and it was supposed that malnutrition was causing chronic pancreatitis. Now the evidence is that malnutrition is the effect of chronic pancreatitis rather than cause of chronic pancreatitis. Also, patients have lesser chances of developing diabetes mellitus. Earlier it used to be like 70-80%. The multi-center study has shown that only 40% with chronic pancreatitis have diabetes mellitus, and they also have a milder course. So, the aggressive course of idiopathic chronic pancreatitis is not seen there. And there is definite gene environment interaction. As we all know, alcohol consumption has increased, tobacco consumption is increased. Also, there is interaction between the pollutants, and so there is some interaction between the genetic factors and the environmental factors, which is causing the idiopathic chronic pancreatitis in India. So, when should we do genetic testing? We looked at chronic pancreatitis, we looked at the risk factors, what minimum risk factors we need to evaluate, and if they are not there, when we should be doing genetic testing. If there is young age of onset, that is less than 35 years, we don't find a clear etiology. That Tigaro classification, there is no clear etiology. We can't find, there is no alcohol, no tobacco, no smoking. We can't find a metabolic cause, then genetic testing is required. If there is a family history of pancreatitis, and if you have done a therapy, like somebody has biliary pancreatitis, you have taken out his gallbladder, taken out his gallstones, but he develops pancreatitis again, then there might be something else which is going on rather than the gallstones itself. So, disease persisting after therapy, we can look about genetic testing. So, the genes I have tabulated here. Again, I am saying that there are multiple genes. In Indian scenario, SPINK1 gene is the important gene, more common. Again, CFTR is also more common. If the time permits, can we go on to just 2 slides about autoimmune pancreatitis? Usually presents in older age male patients, recurrent abdominal pain with jaundice, and imaging is typical sausage-like pancreas with there will be dilatation of pancreatic duct, And there will be extra pancreatic disease also. There can be type 1 and type 2, and elevated type IgG4 levels in type 1. And it is a steroid responsive disease. Diagnosis is by imaging, and you can do an EUS FNA, and histology will also be confirmatory. And the last slide is about pancreas divisum. Pancreas divisum is a anatomical embryological abnormality in which there is failure of fusion of dorsal and ventral pancreatic ductal system. The major ductal system now drains to the minor papilla, but the prevalence is very high, around 10% of Western population have it, but only less than 5% of patients who have pancreas divisum have any kind of pancreatic disease. So whether pancreas divisum itself is causing chronic pancreatitis, we are not very sure. There may be other genetic factors which are contributing, and the treatment is minor papilla endotherapy. So again, an MRI image showing a chronic pancreas, a pancreas divisum. And I thank you all for your patient hearing. And I thank you again, VSA and DDS for inviting me. Thank you.
Dr. Amit has covered the topic so well that I don't think there are any questions.
Thank you,
so
sir.
I think, thank you very much, Amit sir.
Thank you.
And we proceed to the next session. Thank you.
Thanks, Amit, for a wonderful exposition of a very difficult and complex topic. I thank my chairpersons, Dr. Ladukar, Dr. Ravi Telkar, Dr. Gupta sir, and Dr. Vaibhav Banait for taking us through this session. Next session is on is there a role of medical management for pain of chronic pancreatitis, and we have Dr. Rupjyoti Talukdar to address us on this. May I invite the chairpersons, Dr. Shirish Chaudhary, Dr. Sagar Patil, and Dr. Ghansham Chude for this session. So friends, as you will agree, half the job was done by Yogesh by conceiving this conference. The rest half is been done by the three giants, the guest faculties, Dr. Rupjyoti Talukdar, Dr. Amit Maydeo, and Dr. Sadiq Sikora. I would express my personal debt and gratitude to all these stalwarts who took all the pains on a Sunday morning and address us on all the vitally important topics related to pancreas. And the conference would not have been this big success without all three of you. So that's on behalf of both the societies I speak, DDS and VSA. Over to you. Over to the chairperson and then Dr. Rupjyoti.
Request Dr. Rupjyoti to go to this lecture. Thank you.
Thank you very much. And so this is a very conscientious topic that Dr. Prashant has given me.
Please keep your mic up. Yeah.
Is it okay now? Yeah. So let's begin with temptations. So this is a patient, 40-year plus patient of around 8 years of disease, recurrent abdominal pain. This is the morphology of the pancreas. So we have both surgeons and endoscopists here. So what would you do for this patient? How many would go for surgery? Raise of hands. Okay, I have 1, 2, 3, 4. Endotherapy? ESWL? Okay. Probably many of the hands are not raising because you might be thinking, is intervention really going to help this patient, this particular patient? And if it helps also, how durable would be the response? Probably many of you are thinking in these lines, right? So when we talk about chronic pancreatitis or think about chronic pancreatitis, this is the image that comes to our mind, atrophic pancreas, large stone, dilated duct. But in reality, what we often tend to overlook, this disease begins many, many years before the morphology that I had shown. And this is how the natural history would look like. In the initial stages, it would be like recurrent acute pancreatitis. It may be clinical, may be subclinical. And then the early changes will happen, which is definable by endoscopic ultrasound if done at the right time in the right hands. There will be some strands and there will be some hyperechoic foci. No gross stone ductal dilatation. And then comes the ductal dilatation, which is pretty advanced, with stones or no stones. And finally, the end-stage disease. Grossly atrophic pancreas, there will be endocrine, exocrine insufficiency. So it's very important to understand that the primary pathology or pathophysiology of chronic pancreatitis is not within the duct, it's in the parenchyma. It begins in the acinar cells, and what we see in the duct is a result or complication of the main pathophysiology. This is a very important concept that has lots of connotation in the treatment later on. So again, the most important aspect of this pain is recurrent intractable pain of different types, which may change in character as the disease progression happens. And most importantly, we would be interested to give at least short-term relief to these patients to begin with. And that we can do just by following the WHO ladder. In my personal experience at AIG, we start off with a low potency narcotic like tramadol hydrochloride or tapentadol. One thing is important to understand that morphine analog should be avoided. High potency morphine analog should be avoided because of its dependence potential. It may lead to narcotic bowel syndrome if the patient is chronically on morphine derivatives, high potency morphine. His pancreatic pain may be settled by the medical therapy, endotherapy, but he may get a new disease called a narcotic bowel syndrome. That may give the pain, which often mimics pancreatic pain. So that's important. And then another thing that is very less often discussed is something mast cell degranulation. So when the pathophysiology is going on, inflammation is going on, there is lots of mast cell infiltration into the pancreatic parenchyma. And because of this inflammation, they start degranulating, causing release of mast cell tryptase, and tryptase increase in inflammation. So even though morphine derivatives initially gives the satisfaction to both patients and doctors, so the pain is coming down, we may be setting the stage for further inflammation later on by doing mast cell degradation. So it's very important to avoid high potency narcotics. Now, as I talked about the disease happening much before the morphological changes, so what happens actually that time? The first thing is whatever with the pathophysiology, be it smoking, alcohol, pressure in the duct because of the strictures, stones, or genetic factors which causes trypsin autoactivation, or this inflammation that causes activation of something called the pancreatic stellate cell. Again, lots of biological events have been discussed so far. I don't have time to go through that, but this produces lots of reactive oxygen species and free radicals. The body, the nature has made the body in such a way that these naturally occurring free radicals are neutralized every day, even for you and me. But as the disease progresses, this naturally occurring antioxidant defenses gets depleted and the patient goes into pro-oxidant state. And that is what causes the activation of different immune cell and inflammatory pathways. And that is what causes the perpetuation of inflammation. And again, inflammation causes stellate cell activation. So this becomes a vicious cycle. And this is what I call the mechanistic target of chronic pancreatitis treatment. And logically, what happens at this point, logically the treatment would be antioxidants, because the oxidative stress will cause activation of this nociception, pancreatic pain receptors within the pancreas and the nerves, and that leads to transmission of pain that leads to recurrent pain. So antioxidant is here logically the most important option. Again, there are several antioxidants available in the market, but which antioxidant work well in this? The antioxidant should contain this cocktail, at least methionine should be there. Why? Because there is something called transsulfuration pathway which gets depleted in this acinar cell, and that leads to recurrent inflammation. And methionine is a methyl donor, and vitamin C is a thiol donor, so that will replenish the transsulfuration pathway, and the recurrent intraacinar inflammation comes down. And this actually has been proven in this meta-analysis, where the combination of this group of methionine containing antioxidant has a significantly higher odds in favor of pain reduction with a number needed to treat of 5. Statistically, anything less than 8 is supposed to be a good number needed to treat. But then we have to understand which patients do not respond to antioxidant. Again, this is a common problem we always discuss in these meetings. So patient who has been taking alcohol and smoking actively, elderly patients and patients on chronic morphine or derivatives. These patients are those who is very unlikely to respond to antioxidant therapy, and this was proven by the study by Sirivardena that was published in 2012. But fortunately, the Indian patients that we have, we just heard about the etiology, most of them are idiopathic younger patients, and we don't use long-term high-potency narcotics. So the Indian patients are likely to be responding to antioxidant when started early on. So methionine-containing antioxidant preparation should be initiated early on in chronic pancreatitis. Now as the disease progression from the early stage, in a few years' time, it will develop all the morphological features.
like the calcification, the stone, ductal dilatation, strictures. And what happens at that time is, again, this is a basic science study which elegantly shown that if the pancreatic stellate cells are subjected to high pressure, they start producing oxidative stress. And we now know that in humans there are oxidative stress. So if we extrapolate this to the clinical scenario, if there is ductal hypertension or pressure or even interstitial hypertension because of the stone in the head or multiple strictures all throughout, that will cause activation of stellate cell and oxidative stress. And now we are trying to measure the pancreatic. It's very preliminary study in association with, in collaboration with Johns Hopkins. Dr. Sandeep Lakhtake is doing the intraductal pressure measurement. I don't have the data now, but hopefully if we can get some good data, ductal pressure may help us decide which kind of endotherapy can be done. So now at what happens, so these are the ductal events. I call it the ductal events because now we are dealing mostly with the duct and of course some part of parenchyma. So at this stage, some of the evaluation becomes very important before deciding the mode of treatment, be it endotherapy, be it surgery, or be it continuation of medical therapy. So the pancreatic volume has to be evaluated. Of course, it's not easy, or just a cross-sectional imaging may not give the exact volume, but a bird's eye view or eyeball view may just give an idea if the pancreas is grossly atrophic or not atrophic. Then it's important to look for the pancreatic ductal calculi. Is it only on the head region, tail region, or is it a pan-ductal calculi? That helps in the decision which modality would be more favorable for that patient. And of course, the ductal morphology and MRI would be, MRCP would be the best modality to look for strictures, the position of strictures, number of strictures. And most importantly, these patients, most of them are idiopathic, so they are at the high risk of developing pancreatic neoplasia, cancers. So it's very important to look for local complication, especially mass lesion, before planning to initiate therapy in these patients. So again, these are what I call morphologic targets. Ductal clearance has to be done, and we have two stalwarts, endotherapy and surgery. So I won't deal with this part. So decision on surgery or endotherapy, maybe Dr. Sikora and Maydeo can debate and have a friendly fight. But then let us see what happens after surgery. So this is more important from medical perspective. So this was a very important study that was published, I think several years back, where pancreatic endotherapy versus ductal drainage was evaluated. It's a head-to-head randomized control trial. Primary outcome measure was SBK pain score, and the treatment first follow-up was at 2 years. So if you see here, surgery had a definitely advantageous position in pain relief at the end of 2 years with a very good difference in p-value. But when the same authors published the follow-up of this study after 5 years, if you see here, the main outcome measure, the significance was gone, which means that if we follow these patients for a longer time period, the benefit of surgery tends to come down. It's not only about surgery. If we look at the endotherapy literature, so these are all ESWL and ERCP patients. And if we see the patients who had a shorter follow-up, like 14 months, and these are studies from our center, 6 months, there is a very good response to pain relief, over 80%. But if these patients are followed longer, so this is another study from our center, more than 5 years follow-up, almost 5 years follow-up, there is a significant reduction in the persistence of pain relief. So as duration of the disease increases, whatever you do surgery, you do endotherapy, you do total pancreatectomy, the proportion of patient coming back with pain will be higher. So, but one benefit that we find in early ductal decompression, be it surgery, be it endoscopic treatment, is if these patients do not develop diabetes at the time of endotherapy or surgery, then they have a benefit of the delay of the diabetes by around 4 years. So this especially happens with patients with idiopathic chronic pancreatitis. But if the patient has diabetes at the time of ductal decompression, diabetes probably does not change much. We cannot change the course. But diabetes, absence of diabetes at the time of endotherapy or surgery could delay the development of diabetes. So now the question is, after all this endotherapy or surgery, there will be two scenarios. The patient comes back to you with pain. So one scenario is the patient may have a persistence of the PD stone or stricture, or there could be new onset PD stone that is causing obstruction, could be a mass lesion, local complication. So this group of patient is easy to, you can just repeat the endotherapy or surgery that you had done to clear the duct. But the more complicated patient would be in this second scenario where the patient comes back with pain who has an intact sphincterotomy or a intact LPJ, anastomosis, who do not have stone or maybe some floating multiple stone. So why are these patients having the stone? So this is where let's discuss something called sensitization. So what happens as the disease progresses, initially there will be sustained pain receptors because of oxidative stress. And the important thing is even after we remove the pancreatic ductal stone or do a surgery, we are not removing the activation of stellate cell. Unfortunately, we do not have any medication to stop the stellate cell activation. So that keeps on happening in spite of the surgery. So what happens then, there will be in the initial phase, only the pancreatic segment of the spinal cord, which goes through the celiac ganglion, gets activated. But as the persistent stimulation keeps on happening, there will be inflammation in the spinal cord, the dorsal horn ganglia, and whole spinal cord above and below the celiac ganglion segments also gets sensitized. So at this stage, if you even block the celiac ganglion, remove the celiac ganglion, still the patient could have pain, because now even food in the stomach or intestinal motility or even the normal function of pancreas, just like secretion of enzyme, may give rise to persistence or perception of pain in this patient. So this is called spinal hypersensitivity. And if this keeps on happening, at a certain time point, there will be the whole neural architecture in the brain that modulates pain gets altered. The pain threshold comes down, and there are lots of other changes. So this is what neuropathy is all about, and neuroplasticity. So now coming back to our old patient with this morphology, in fact, he underwent stenting somewhere elsewhere, and there was no relief of pain. And it is very unlikely that this patient would be benefited by pain by any kind of endotherapy or surgery, because there is no parenchyma left for oxidative stress to be generated. And this is a long-standing disease. So that is why it's very important to understand the patterns of pain. Usually what happens in the routine clinical practice, we just ask, do you have pain, do not have, or you have a pain or not. But just yes or no is not enough here. It's very important to understand the pattern of pain, and we have to actively or proactively ask the patient about what kind of pain they have. For example, the patient may have a persistent pain with slight fluctuation. The patient can have persistent pain with pain spikes or episodes, which are probably acute exacerbation. And these are typical acute exacerbation, and then there will be undulating pain. So it is very important to ask, be it a surgeon, be it an endotherapist, be it a medical pancreatologist, to ask for the pattern of pain, the character of pain, what are the pain triggers? Is it diet? Is it starvation, stress? In fact, you might find many young students, boys and girls, who have chronic pancreatitis and have recurrence of pain just before their exams or before they have an activity in the, or some assignment in their schools. So that is very important. So that stress, that is a stress factor that triggers the pain. And many a times there will be spontaneous pain. Important in the change in characters, all these things should be proactively asked. And then this might indicate the presence of neuropathy. So in the routine clinic, how to identify neuropathy? So that is something called quantitative sensory testing that we are doing now. And it's actually still a research tool, not routinely available, and very few centers all over the globe are doing. So we induce temporal sensitization to the patient by giving pinprick sensation, or we look at the EEG and ECG response, autonomic response to pain, and do different kind of calculations. And based on that, you can classify the patient as normal or no neuropathic pain, or segmental sensitization when only the pancreatic segments are activated, or widespread sensitization where several other segments beyond the pancreatic segments are activated. And this is widespread sensitization or neuroplasticity. But then you may ask me, why are you showing us that? Because it's not available, what can we do in our practice? So that's to answer that question. Actually, we had done this study to look at the clinical surrogates, and again, the study is just completed with over 500 patients. I won't go into details for need of time. But basically, if the patient has involvement of new areas of pain, if the patient has long-standing diabetes and significant depression, so these are the independent risk factors that will tell us, yes, that the patient is having neuropathic pain. So a detailed history of pain is good. So in this kind of patient, pregabalin is the drug of choice. So this has been shown by the Denmark group that pregabalin can reduce pain in this kind of patients, and we after that conducted a RCT combining pregabalin with antioxidant, and we see the same results. The pain response is sustained over 6 months, 9 months period of time. And then finally, the last 1 minute is just like any other chronic disease. Even in chronic pancreatitis, the patient will have anxiety and depression, long-standing disease, lots of pain, lots of cost factor involved, lots of poor quality of life. And what happens in chronic pancreatitis is there is change in the, I don't know if you can see here, some graphs are there. So, so this is another study we published last year where we could show that there was significant change in different metabolites, especially something called N-acetyl aspartate in the hippocampus. And hippocampus is the seat for pain, emotional responses to pain, and a long-term pain memory. So when these patients are counseled about their disease, taught about their disease, if you see here, this is before counseling or education, but after you counsel, almost 3/4 of the patient had depression was not there and the pain was significantly low, just by talking to them and explaining about their disease and counseling. And when we looked at the other parameters, depression score, pain episode, pain score, all this improved after counseling. So this is another treatment option which can be benefit the patients. So finally, if we look at the dynamic change in the pain mechanisms, like earlier, pain transmission was the main mechanism, pain transmission from the pancreas to the thalamus. But as the disease progresses, it becomes a matter of more of pain perception and pain experience, because many other areas like the hypothalamus, hippocampus, prefrontal cortex, anterior cingulate cortex are involved, and these are the areas of pain processing, long-term pain memory, and emotional responses. So this is what I call the holistic insight of the pain mechanism. This is already known, pancreatic morphological changes, inflammation, but now we also have the information or data on the altered brain metabolites that could change pain perception, widespread sensitization, descending inhibition. There could be several other factors like anxiety, depression, and all these triggers and quality of life. So it's very important to look beyond the pancreatic duct. Whenever we treat this kind of a patient, duct is important, endotherapy is important, surgery is important at the right time, but it's not the holy grail in the treatment. It's extremely important to look beyond the duct. And finally, this is the take-home message. A patient with chronic pancreatitis, antioxidants should be started from early on. If the patient's morphology is completely altered, if there is no parenchyma left, those patients won't be benefited by antioxidants, so we need not give in those patients. Of course, interventions like endotherapy, surgery should be done when the patient with morphological changes are symptomatic, but again, there is a tendency of pain to come back in this patient later on. So in those situations, neuromodulators may help. There are no hard data on antidepressant, but many people do use antidepressant and report some benefit. And of course, the patient has to be counseled all throughout, multiple sessions of counseling, nutrition, and cessation advices. Thank you, and I'd be happy to take questions.
Any questions?
Thank you, Dr. Rupjyoti sir, for your very informative talk on the management, etiopathogenesis, and basics of pain management in chronic pancreatitis.
Thank you.
Thank you very much.
Dr. Rupjyoti, can I ask you a question?
Yeah, sure.
This pancreatic enzymes were conspicuously absent in your entire talk.
Yeah.
So, just for the benefit of once for all,
I know.
say the last word on that.
And
So,
same thing,
yeah,
I wanted to ask, and just to add on it, as your any role of uncoated preparation.
Exactly. In fact, just now I took my laptop and removed those enzyme slides because of the lack of time you had requested. So anyway, we can discuss that quickly. Enzymes are of two types. There was a meta-analysis, actually two meta-analysis of more than 10 studies which looked at enzymes, effect of enzyme on pain. There was no benefit. When they did a subgroup analysis, there were 2 studies with uncoated enzymes, and that showed some benefit in pain. So, and the concept was, if the uncoated pancreatic enzymes are given, they will block the CCK receptor in the duodenum, so that those blocks the feedback loop. So there is no pancreatic enzyme secretion, no ductal hypertension, no pain. So that's the hypothesis. And now I think the uncoated enzymes are available in the market, and many of you must be using that. But we still do not have hard data on that. coated enzyme should not be used for pain, they should be used only for digestion. But uncoated, actually, we are doing this randomized control trial using uncoated enzyme, and we are halfway through. So hopefully by end of this year, we should be able to come with the result. But most important thing is in the uncoated enzyme, protease level should be very high. It should be at least 25 to 30,000 units of protease. For digestion, coated enzyme, it's like lipase, but for pain, it should be more protease.
Okay. Thank you, Dr. Rupjyoti, for wonderfully doing full justice to this topic as I had envisaged. The next, I would like to thank the chairperson, Dr. Divish Saxena. Oh, sorry. Dr. Sagar Patil, Dr. Shirish Chaudhary, and Dr. Ghanshyam Chude for sharing us through this session. The next set of chairpersons is Dr. Divish Saxena, Dr. Sachin Sardesh Pandey, and Dr. Samir Patil. And the talk is on management of pancreatic exocrine insufficiency. And the speaker is one who lets his work do the speaking, very shy of public appearances, Dr. Amit Agrawal. So over to you, Amit.
Good afternoon, everyone. Thanks to VSA and DDS for this opportunity. Today I've been given the task to speak on the management of pancreatic exocrine insufficiency. Now, pancreatic exocrine insufficiency is defined as inadequate intraluminal pancreatic enzyme activity that leads to maldigestion and subsequently malabsorption of nutrients. It is divided into two types, primary and secondary. Primary PAI, which we often see, there is lack of exocrine pancreatic tissue and that leads to disturbances in the postprandial pancreatic secretion, which is commonly seen in patients with chronic pancreatitis and also in cases with cystic fibrosis, necrotizing pancreatitis, and periampullary tumors, when the tumors blocks the pancreatic duct and that prevents the release of the pancreatic enzymes in the duodenum. Secondary PAI is defined as inadequate mixing of the enzymes with the chyme that is normally seen in patients who undergo surgeries when there is asynchrony between the pancreatic enzyme release and the delivery of the nutrients in the duodenum. Second, it may be seen in intestinal diseases like celiac disease and Crohn's disease when there is disturbances in the mucosal epithelium that leads to inadequate release of the CCK that causes activation of the pancreatic enzymes from the pancreas, and also in certain conditions when the duodenal pH is low, for example in Zollinger-Ellison syndrome, and that causes increased degradation of the lipase in the duodenal lumen. The prevalence of PEI is quite high. In almost all types of pancreatic disorders, we see the prevalence of PEI somewhere in the range of between 50 to 70%. But the important point here to note is that in patients who have extra pancreatic disorders, especially patients who have diabetes, celiac, inflammatory bowel disease, most of these patients also have underlying pancreatic exocrine insufficiency. And this is the area where one should look at the subtle symptoms of pancreatic exocrine insufficiency. This should be investigated, and if found, then they should be treated, and most of these patients benefit from these type of interventions. Symptoms are quite common. Patients normally present with symptoms secondary to carbohydrate malabsorption. The symptoms are predominantly like discomfort, bloating, increased flatulence. This is because of increased carbohydrate substance delivered to the small and large intestine that pulls a lot of water inside the intestinal lumen and causes all these symptoms. Weight loss is secondary to malnutrition, maldigestion and malnutrition. Steatorrhea, which is classically seen in patients who have more than 90% of the pancreatic dysfunction, it is defined as loose, greasy, foul-smelling, voluminous stools that are difficult to flush, float, or stick to the bowel, and sometimes patients classically gives history of passage of oil droplets in the stool, as can be seen in the picture. About the diagnosis, we all are aware about the fecal fat estimation, which has been gold standard in the diagnosis of pancreatic exocrine insufficiency. When the 100 grams of fat is fed to the patient for 3 days and fat estimation is done, if the fat content is more than 7 grams, we label the patient is suffering from PEI or steatorrhea. Second is the C13 and mixed triglyceride breath test, where the radiolabeled isotope is mixed with the test meal. It is digested, and the CO2 which is released is measured with the breath analyzer, and it is directly proportional to the amount of fat which is digested, and that also gives an idea about PEI. Both these tests are not routinely available. The most common test which we do in our clinical practice and which is commonly available at almost all places is fecal pancreatic elastase. So it is a first line test. It is an exocrine specific enzyme that is not degraded in the bowel lumen, is concentrated during intestinal passage, and it reflects the total overall pancreatic secretion. The beauty of this enzyme is that it remains stable at room temperature for around 4 days, and when it is frozen, it remains stable for around 30 days. Very good sensitivity and specificity. If it is less than 200 micrograms, it is called as moderate PI. If it is less than 100 micrograms, it's called a severe PI. Sensitivity is also good. It is 25 to 65% with mild PI and almost 100% sensitive for severe PEI. Specificity is also good, around 55 to 100%. One should be cautious that it should not be measured in patients who have voluminous or liquid stools because the test gets diluted. So always it should be measured in solid stools only. Now the next question comes, whether all patients should be tested or not. The answer is no. All patients doesn't require testing. There are specific clinical condition. When it is there, these patients should be directly started on PERT, especially in patients who have chronic pancreatitis, having steatorrhea and malabsorption symptoms with dilated pancreatic duct or severe pancreatic calcification or CT or MR, patients who have pancreatic head masses, even before surgery and after surgery, these patients should be started on PERT, patients who undergo total pancreatectomy, and severe necrotizing pancreatitis in initial phases. Patients who need to be tested, if the patients are having subtle symptoms of bloating, belching, and flatulence, and especially if the patients are having extrapancreatic disorders which have a higher tendency of having underlying PEI, this patient should be tested with fecal elastase, and if the levels are low, then this patient should be treated. Now, in normal health, most of the fat and fat-soluble vitamin absorption occurs in the duodenum, with little or less in the jejunum. So the aim of the pancreatic enzyme therapy is to provide activated digestive enzymes to the duodenum during the prandial and the postprandial period, and to avoid steatorrhea, maldigestion-related symptoms, weight loss, and malnutrition-related morbidity. So what is an ideal PERT? An ideal PERT should resist inactivation by gastric juices. It should intersperse well with the chyme. It should empty from the stomach simultaneously with the nutrients, and it should release enzymes rapidly in the duodenum and proximal small intestine. So these are 4 important characteristic features of an ideal PERT, and now we have almost all brands with enteric-coated pH-sensitive pellets that produce the enzyme from the denaturation by the gastric acid. Because of the granular nature pellet form, they have larger surface area and mix adequately with the chyme. Small size, less than 2 millimeter, allows them to migrate easily along with the nutrients across the pylorus into the duodenum. As far as dosing is concerned, most of the guidelines says that the dose varies between 20 to 40,000 units of lipase per ml. So it's lipase which is almost looked at in the preparation when we give this PERT to the patients. The UK practical guidelines, which is the latest published last year, says that the 50,000 units should be given with every meal, and half the dose should be given with snacks or minor meals. If the patient doesn't respond to the treatment, dose escalation can be done every 4 to 6 weeks with proper evaluation. Whatever we give the dose, the aim is to avoid symptoms and normalize digestion to prevent malnutrition and malnutrition-related morbidity. So our aim is to improve the symptoms and improve digestion, so the dose can be escalated gradually depending on the response. So whenever we talk of pancreatic enzyme, we always talk of lipase. Why not amylase? Why not proteases? So the fat digestion is the most important digestion part in GI system as compared to carbs and proteins. So inability to digest fats leads to a lot of clinical symptoms and complications related to mortality. Lipase is very sensitive enzyme. In pH less than 4, it is usually seen in patients with chronic pancreatitis due to reduced bicarbonate secretion. It rapidly gets destroyed. Proteolytic degradation of lipase is also more as compared to amylase and proteases. And as compared to carbs and proteins, there is minimal extrapancreatic lipolytic enzyme production. So the lipase is the most sensitive enzyme, and it is assured that if the fat digestion is good, probably the protein and the carbs digestion is almost optimum. The dose of PERT is variable depending on the age and the weight of the patients. So one can take the help of this chart and to give the PERT in infants, children, and adults as well. The most important point, one should look at the maximum dose of PERT which can be given. So the dose should not exceed more than this, because these pellets have acidic enteric coating, When it is delivered in a large amount in the colon, it can cause colonic ulcerations and subsequent problems in the form of colitis and fibrosing colopathy. Now, timing of PERT is very important. The rationale is that it should mimic the action of own endogenous pancreatic enzymes, where secretion from the gland occurs throughout a meal. Normally, we ask the patient to take the dose with the first bite of the meal and add extra enzymes towards between the meals and towards the end of the meal. The problem is that if we give PERT very early, then most of the PERT will cross the pylorus and reach duodenum without mixing with the nutrients. If we give PERT very late, most of the nutrients will cross the pylorus without mixing with the PERT. So the most important question we should ask the patient how much time he takes to finish off the meals. If the meal is consumed in less than 15 minutes, all enzymes should be given at the beginning of the meal. If the meal is consumed between 15 to 30 minutes, half dose with the first bite and half in the middle. And if the patient takes around more than 30 minutes to finish off his meal, it should be divided into 3 parts, and it should be given before the first bite, middle of the meal, and at the end of the meal. There are certain scenarios when the patient is not able to swallow the tablets. So the capsules can be opened up. The contents are mixed with the acidic medium. Acidic because these are, if you give alkaline medium, the entry coating will dissolve and the enzymes will release prematurely. And it should be swallowed immediately. Wash the mouth with cool water to ensure that no granule should be in the mouth because it can cause ulcerations. The most important thing is that the granules should never be crushed or chewed because it will remove the enteric coating and premature activation of the enzymes will be there. Now, baseline assessment is very important whenever you start PERT in patients with pancreatic enzyme insufficiency. It gives a basic idea what the quantum of malnutrition the patient is suffering from. Second, it helps in further assessment after 4 to 6 weeks whether the patient is responding to treatment or not. So the basic body mass index, muscle strength can be calculated. There are a lot of basic nutritional parameters which can be measured, but these are very costly. Few of them are very costly. So, and second important thing is you should do DEXA scan because most of these patients have underlying osteoporosis due to vitamin D deficiency. Though it is a common practice to avoid fat in patients with pancreatic insufficiency to reduce symptoms, but already these patients are malnourished. So restricting fat will increase or further enhance the malnourishment in such patients. So fat restriction should be avoided. On the contrary, higher amount of fat is required, 40 to 70 grams per day or 30 to 40% of the total calories, and it should be associated with high protein diet as well. Supplementation of fat soluble vitamins should be there. You can avoid high fiber diet because it sometimes absorbs the enzyme and it may delay the nutrient absorption. Abstinence of smoking and alcohol is very important as it may exacerbate further pancreatic damage. Now, once you have started PERT, after 4 to 6 weeks, you should reassess the patient whether the patient is responding or not and whether the patient needs dose escalation or not. So the most important parameters we should look at the anthropometric body mass index and functional changes like grip, strength, sit to stand times, walking, physical activity of the patient, and second being clinical, whether the patient's symptoms have disappeared or not, whether the steatorrhea has subsided or not. Second, one should always also look at the medications which the patient is taking because some medications may mask the symptoms and may give a false diagnosis. Biochemical and dietary assessment can also be done. Now, there is a common problem that you have started PERT and the patient is not responding. So what to do? So there are stepwise management is there. One should always look for the compliance because these patients need multiple tablets multiple times. The compliance is a very big issue in this patient. Poor diet, because of the increased fat in the diet, most of these patients avoid high fat diet. So they should be assessed whether they're taking the diet or not properly. Timing and dosage is very important. If the dosage is insufficient, you can increase the dose, but always remember maximum dose should not be crossed as it can cause complications. If the timing of PERT is not proper, you should reassess the patient and ask the patient to take timely before meals, in the middle of the meals or after meals. These enzymes are very heat labile and acid labile, so you should ensure proper storage and add concomitant PPI. This is a common practice to add PPI with the pancreatic enzymes, and it helps in patients who are not responding to routine doses of PERT. If symptoms are not controlled, always look for some other causes of steatorrhea or diarrhea. So there are a lot of list of things which can happen and which can cause similar type of symptoms. So those should be ruled out. And if nothing works, then switch the formulation, change the brand. The common practice among all of us to start PPI on day 1 along with PERT. Definitely it helps by increasing the duodenal and the gastric pH. It prevents denaturation of the enzymes, and it improves the delivery of the enzymes in the duodenum by keeping it more than 6. However, it has been found that it is usually helpful in patients who are not responding to PERT alone. As you can see, this is in this study, patients who were on enzymes, when they were added on PPI, the patients who were not responding initially started having better fat digestion. So PPI really helps in patients who are not responding to routine PERT therapy. Adverse effects are almost minimal, no significant side effects. There is one entity which is called as fibrosing colopathy, which is seen in children with cystic fibrosis because these patients require higher doses of PERT. So as I mentioned, these are toxic acidic entry coating, which when it is given in bulk, it goes into the colon, causes ulcerations and fibrosis. So one should always look for this type of complications if developed. Now coming to the most difficult part to which one to select among all these type of brands. Very difficult. The most important factor which I found in my practice is the cost. The cost of these capsule varies from 15 rupees to 65 rupees. So it all depends on the finances of the patient, which one to choose. We have one very good study published last year, which was in India only, where in vitro comparison of various pancreatic enzymes were done in the Indian market, and a lot of parameters were assessed. It was found the most important parameters were the particle size distribution and water content, and third one was the enteric coating resolution. So it was found there was a gross difference between the water content and the particle size distribution, which affected the in vitro performance of the particular brand, as well as the enteric coating resolution was delayed in a lot of brands that affected the enzyme release. The limitation of this study was it was an in vitro study. How much correlation is there between the in vitro performance and the in vivo performance of these brands? That is questionable. It really needs further evaluation and research. Long-term follow-up is equally important. Most of these patients require lifelong treatment. So one should never forget to titrate the dose of the PERT at yearly on annually basis. Similar parameters can be used because the dose may vary from time to time, and that should be assessed properly. Now there is growing evidence that the PERT is very much helpful in patients who have carcinoma of pancreas. So because of the ductal obstruction, the enzyme delivery is hampered in patients who have carcinoma pancreas, and the duodenal enzyme levels are very low. So in this meta-analysis was found that patients who received PERT, they have better survival rate as compared to patients who didn't receive PERT. So PERT should be considered in patients who have carcinoma head of pancreas. It has been found that the prevalence of PE and advanced pancreatic cancer is around 72%. Prevalence is higher in patients who have tumors located in the pancreatic head with relative risk of 3.3, and the PERT is associated with 3.8 months improved survival benefit. So we should also always consider PERT in patients who have carcinoma head of pancreas. So to summarize, all patients doesn't need diagnostic tests. There are few indications where you can directly go ahead with PERT therapy. Investigations are not required. Aim is just to not to avoid symptoms, but also to maintain and ensure normal nutritional status of the patient. Look at the non-pancreatic diseases as well, who have subtle symptoms of pancreatic exocrine insufficiency, and if it is found, investigate them and treat them if the diagnosis of PE is confirmed. Oral PERT with enteric coated macrospheres, which are the size of less than 2 mm, are the therapy of choice. Addition of PPI helps in patients who have insufficient response to monotherapy, and therapy should be individualized based on the objective evaluation of the nutritional status. Thank you.
Amit, I have one question regarding vegetarian patients. So how do you counsel, or how difficult is it to convince them to take PERT?
So the enteric coating is pork based. So we don't have any other option, just to inform them. Normally we don't tell them that what is the enteric coating of the, I mean, I'm sure everybody will agree with that. It's a common practice just to prescribe PERT. Nobody has asked what kind of coating is that. So it's better not to inform the patient.
Patients who are on NJ feeds or continuous feeds. So how do you actually adjust the supplements in this?
Yes, I intentionally deleted the slide because of lack of time. So and there are a lot of places. The pancreatic powder is also available. So this can be given in two forms. It can be given as flushes, or it can be mixed with the feeds. So this, if you are giving it in flushes, never inject water in between the feeds and the enzyme preparation. If you are giving it with mixing it with feeds, it should be given within 4 hours of its preparation, and it should be given in a slow form. Third, it can be given as just I mentioned that open up the capsules, take out the pellets, and mix it with feeds, and it can be given along with the feeds as well.
Thank you, Dr. Amit, for a comprehensive coverage. Just one question to ask. We have seen, we have gone through the patients who have been discharged with acute pancreatitis, been prescribed with enzymatic replacement therapy. So, can we prescribe it in cases of acute pancreatitis also
So
on
patients,
discharge?
yes. So patients who have necrotizing pancreatitis may benefit from pancreatic enzyme PERT therapy. Patients who have more than 30 to 50% necrosis do better with PERT. Patients who doesn't have necrotizing pancreatitis, the use is not so much helpful. It should ideally be given for initial phase like 2 to 3 months, and after that one can do elastase test whether the patient is really having pancreatic exocrine insufficiency, and if it is found then it can be continued, otherwise it can be stopped. So initial phase necrotizing pancreatitis, definitely it can be given.
Thank you, Amit, for in-depth tackling of this important topic, and thank you chairpersons Dr. Devish, Dr. Sachin and Dr. Samir for chairing us through this session. Next session is on endotherapy in chronic pancreatitis, once again by the star speaker Dr. Amit Maydeo, and the chairpersons are Dr. Amol Samarth, Dr. Dhananjay Kane and Dr. Manish Upvanshi. Dr. Amol Samarth.
Surgery for chronic pancreatitis, and Dr. Amit himself is a surgeon turned endoscopist, so I believe he will give good justice to this topic. So over to you, sir.
Yeah. So hello. Yeah. So I'm not going to talk about this topic as a debate between surgery and endotherapy, because I don't think there is any debate. The situation is quite clear. Only thing I want to tell you is whether you practice surgery or you practice endotherapy or whether you are just giving medications. When you are dealing with the pancreas, you have to develop an insight about the pancreas. You have to actually start talking to the pancreas, one-to-one. Only then your therapy is going to be proper, directed, and it will be reaching some goal, not arbitrary. So whatever treatment we do in pancreas should not be arbitrary, because even though you can become friends with the pancreas, pancreas cannot be trusted. So you have to be very careful the way you treat it. Now what I want to tell you is, we have seen so many studies, so many results, and comparative studies published in NEJM, even a randomized controlled trial comparing endotherapy versus surgery. But we are comparing apples with oranges. Why? Because chronic pancreatitis is not a simple disease. It has got a varied etiology, varied incidence, and a varied pathomorphology from different parts of the world. For example, from the western regions to the eastern regions, right from alcoholic etiology to tropical etiology. You see here, the entire pathomorphology of chronic pancreatitis, if you see the duct, is totally different. The NEJM randomized controlled trial which was conducted in the West, and they compared surgery with endotherapy, was purely 90% of the patients were alcohol etiology pancreatitis with a complex pathomorphology. This is not going to respond to endotherapy, and in such patients you prove that surgery is superior is not a trial which can be accepted in normal day-to-day practice. Now what do we know of the manifestations of chronic pancreatitis? How do the patients present with? Either they can come with a stone predominant disease or a stricture predominant disease, and most of the times it's a combination of strictures and stones. In addition to that, you may have confounding situations like an associated inflammatory mass, there could be associated pseudocysts, or there could be also a post-CP induced biliary stricture. Now if you were to study the entire published literature on endotherapy of chronic pancreatitis, over the last many decades, you see the level of evidence and the grades of recommendation. What is the evidence? What is the type of literature published? Everything is below 2B and in grades of recommendation below C, C and D. Why? Why is the amount, the type of publications of not high value, high grade? I'll tell you, the reason is that the etiology, incidence and pathomorphology of CP is too variable. Endotherapy technique practiced by many endoscopists everywhere in the world is not standardized. It is difficult, it is labor intensive. Case volumes of pancreatic ERCP are only limited to a few selected centers. Everybody cannot do proper pancreatic endotherapy. Most of the endoscopists have unclear concepts of patient selection and end point of therapy, when to stop and when to refer to a surgeon or when not to select at all. And finally, unavailability or inexperience of using ESWL. In general, if you were to see, why do pancreatic stones form? Nowadays, it is quite clear. Pancreatic stones form irrespective of the etiology because of increased lithogenicity of the pancreatic juice. If you were to study the pancreatic juice in patients of chronic pancreatitis, you will find that their protein content of the pancreatic juice is 400 times that of a normal person. So what happens is these proteins, because of the thick juice, the proteins forms plugs. Plugs block the duct, patient develops recurrent episodes of pancreatitis, and on these plugs calcium goes and gets deposited, and depending upon the amount of calcium, you get soft stones or hard stones. If there is too much calcium, the stone becomes hard. Less calcium, the stone is not hard. Why do strictures form in the pancreatic duct? Classic hypothesis. Nowadays, it is felt that almost all pancreatic strictures and chronic pancreatitis begins because of old and past, maybe subclinical episodes of acute pancreatitis and repeated episodes of inflammation of the pancreas causing inflammation, fibrosis. It's called as the necrosis fibrosis sequence, called as the Kloppel's hypothesis or the SAPE hypothesis. And then once the stricture forms because of inflammation, sluggishness of flow, again a repeat episode of acute pancreatitis, further injury, further stricture. So the patient enters into a vicious cycle. Now, endotherapy of chronic pancreatitis started 10, 15 years or maybe 20 years after endotherapy of CVD stones started. Because many endoscopists of the world, and these were the so-called pioneers of endotherapy of chronic pancreatitis, see 1986 to 1991, just before I started my training in Germany in endoscopy. And what were the conclusions of these initial publications? Pancreatic duct stenting is possible, adverse events are acceptable, 20 to 40%, endotherapy should be done only for temporary use, good bridge for surgery, and it doesn't cause severe injury. The first landmark publication in the world showing that shockwave lithotripsy is very important to do endotherapy came from my teacher Nib Sohendra in 1989, where he showed that any patient of pancreatic stones which are hard should be first pulverized by ESWL, and on 8 patients he showed that he could achieve a complete clearance of the duct. Now we have got very clear concepts. The main indications of treatment of chronic pancreatitis, whether it is surgery or endotherapy, is pain relief. At least for now. Pain can be because of various mechanisms, but we want to achieve a pain relief thinking that ductal hypertension, if you reduce, that patient's pain may reduce. Second possible indication is to improve the exocrine and endocrine function. Many times we get patients of full-blown chronic pancreatitis, not much of pain, but they have exocrine endocrine insufficiency. Some people ask me, should we treat or not treat? We do not follow a fatalistic approach. If there is any chance of improvement of exocrine endocrine function by clearing the duct, we should take that chance. Consider that you are yourself having that. Wouldn't you like improvement in your functions? So, there have been surgical studies which have shown that after a surgical pancreatic jejunostomy, these functions have improved. Neelan et al. Many years back. So nowadays, these are potential or possible indications of therapy. Before we plan any endotherapy, we have to do a mandatory pre-treatment workup. Every patient undergoes a fluoroscopy or X-ray, which many patients who come to me from outside, been treated, a simple X-ray is not done. Why? Why is X-ray important? You can immediately pick up radio opaque stones.
It will not be seen on simple CT scan or MRI, simple X-ray or a fluoroscopy, because radio-opaque stones means your treatment protocol changes. Second is an MRCP. MRCP will tell you the ductal morphology and associated strictures, pseudocyst, complex disease, SOLs, or even a biliary stricture. So these two are mandatory investigations, fluoroscopy and MRCP. You may follow it up with EUS or CT if there is any special situation. Now, pancreatic stones, 90% of pancreatic stones are radio-opaque. That means they contain so much calcium that they are very hard. And they are very unique as compared to CBD stones because they are hard, they are spiculated, they are impacted, and they cannot even be moved inside the duct, and they are associated many times with strictures and complex pathology, and many times they can be inaccessible. And only 10% of pancreatic stones are radiolucent. So what do we do? If you have a patient who is a symptomatic chronic pancreatitis, on fluoroscopy you find radio-opaque pancreatic stones. You have to first do ESWL. We cannot do an ERCP. So if you are going to do ERCP directly and if you don't have access to ESWL, you are not justified in doing endotherapy. Directly send the patient to surgery. So ESWL forms the cornerstone of therapy for radio-opaque pancreatic stones, which is 90% of the cases. And nowadays we have this 4th generation ESWL machine, Dornier Delta 3 Pro, by which we can completely pulverize the pancreatic stones without any intervention, only from outside, and convert it into powder of fragments less than 3 millimeter size. So what is the end point of ESWL? How do you know that you achieved complete ESWL? This is what it looks like. These hard stones, they become powder. You can see them on the X-ray, and in fact they spread all along the duct, which is also called as a Steinstrasse appearance. And in fact, if the stones are very small, located only in the head, sometimes the stones even disappear. The powder passes out of the pancreatic duct. And once we have done this ESWL, only then, once the technician tells us, yes, all the stones are pulverized, maybe 2 or 3 sessions, every session 8 to 10,000 shocks of ESWL, then we perform an ERCP and we remove all the pulverized fragments by doing a pancreatic sphincterotomy, going inside with a stone extraction balloon or a wire-guided Dormia basket. And look at here now, by pulling this balloon here, we can see how these small, minute fragments after pulverization can be taken out. On the left side, you can see they are coming out in a form of a chunk. And you see here now, there is now a recent paper published on the success of ESWL and ERCP in symptomatic PD stones. You can see this is a systematic review and meta-analysis. Complete ductal clearance can be achieved in almost 70% of the times. Now, this is overall world data. In India, it's even better because tropical pancreatitis patients do not have too many pancreatic ductal strictures. Most of the times the duct is dilated, and even if you have stones spread out in the duct, the clearance rates can reach almost 80 to 90% if you do proper ESWL. What if the stones are not radio-opaque, they are radiolucent, but on MRCP they are seen as filling defects? This is even simpler. By endoscopic techniques, you can see here we are doing an ERCP, multiple big filling defects inside the pancreatic duct, but we can do a pancreatic sphincterotomy. Then after following this, we can do a pancreatic balloon sphincteroplasty. We can pass in this balloon, dilate the pancreatic sphincter up to 1.2 centimeters, and then such type of radiolucent pancreatic stones, which are actually protein plugs which are stuck inside the pancreatic duct, but which look like stones on MRCP, you can completely clear the pancreatic duct sometimes in a single sitting of ERCP. But this is seen to maybe 10 to 15% of the times. Most of the times, these are pancreatic radio-opaque stones. What about strictures? Strictures are seen commonly in alcohol-induced chronic pancreatitis. This is not easy. Why? Because strictures are usually associated with a complex ductal morphology. Many times they do well better by surgery. So you may have single stricture, multiple strictures, tight, soft or complex strictures. The first standardized protocol of treating pancreatic strictures came from this center from France. Many years back, you see here, where first time they showed that you don't do arbitrary stenting. If you have a dominant stricture in the pancreas, put a stent inside, readmit the patient every 2 months, remove the stent and see whether the stricture has opened up, and then after 1 year, if the stricture is not opening up, send the patient for surgery. This was the protocol. Then another center showed that if you have a tight pancreatic stricture, instead of placing one stent, because it is a benign fibrotic pancreatic ductal stricture, it is not going to open up with one single stent. So they showed that by placing multiple plastic stents side by side, you could achieve a good result. Today, now the technique to be followed, and most of the centers in the world follow this, that if you have a pancreatic ductal stricture which is dominant, not a duct which is completely full of strictures, not like a beaded chain appearance. If that is the case, it is not suitable for endotherapy. So if you have a dominant stricture, 1 or 2, you can start with a smaller stent first, reach a 10 French stent, leave the 10 French stent inside for at least 1 year. After 1 year, when you pull out the stent, if the stricture persists, then you have to give the patient a choice, whether the patient wants to go for multiple stenting regime or directly for surgery. That's what we do. And if the patient decides to go for multiple stenting regime, then we put multiple stents and wait for another 1 year. If the next year also the patient has non-resolution of the stricture, don't insist on performing and continuing endotherapy. Patient has to be sent for surgery. Good part is, nowadays, we have got fully covered expandable stents which we can place in the pancreas. And with this is like placing 3 plastic stents. And nowadays, now we are treating dominant pancreatic strictures by placing such type of things, which is fully covered expandable stent. You see here, proof of concept study, 25 patients, there was an immediate pain relief in 100%, technical success is good, and immediate stricture resolution is 100%, but sometimes these metal stents can cause further stricture formation inside the pancreas because of irritation. So therefore, these covered expandable stents, and in addition to that, biodegradable expandable stents have come for the pancreas. So what we do now is, with these new stents, instead of placing metal stents, we place biodegradable stents which will degrade automatically within 3 months or 6 months, expand the stricture so much, and with that we will have a reasonably good stricture resolution, but it is presently in the experimental stage. What about bile duct stricture due to chronic pancreatitis? Till now, this was supposed to be a surgical indication, because bile duct strictures, which are because of extrinsic tightness of the pancreatic head, they don't respond to endoscopic stenting. But this is a new paper which has come out, a systematic review and meta-analysis comparing fully covered metal stents for bile duct strictures of chronic pancreatitis, which has shown good result. So therefore, today the main recommendation, if you see here, as far as endotherapy of chronic pancreatitis goes, is endoscopic treatment with or without ESWL, depend upon the stone, is the first line of therapy for painful, uncomplicated CP with obstruction of the MPD. Radio-opaque stones, ESWL first, no ERCP. If there is a painful dominant stricture, put 1 10 French stent, after 1 year you remove it. If the stricture continues, give the patient a choice. And if you do multiple stenting, maximum 2 years you can do endotherapy. Benign strictures in the bile duct, you can place a fully covered metal stent. So friends, I just want to tell you that etiology, incidence, pathomorphology is too variable. Endotherapy technique is not standardized, but nowadays, because of these protocols, every endoscopist who treats pancreas should have a standardized protocol of treatment, not arbitrary. You should know which stent to place, how long to keep, which stone to break, how much ESWL to give, what is the end point. So the concepts have to be very clear, and you have to master ESWL. So the conclusion and take-home messages are all this, what I want to tell you, but you have to remember that surgeon does have a role to play in the treatment of chronic pancreatitis. Sadiq will of course talk about it. Majority of patients of tropical pancreatitis in India, what we see, can be treated by endotherapy, but many times we have a confounding pathomorphology. It's not always as simple as a normal tropical pancreatitis, where these patients also we may have to refer for surgery. Thank you.
Sir, as expected, your talk was nothing short of masterclass. But considering the chaos in endotherapy, would it be a good idea to consider a pancreatic board in lines with the tumor board?
Yes, that would be ideal, because India is known as the pancreatitis country. What was thought to be tropical pancreatitis of Kerala, now we are seeing cis-tropical pancreatitis in many states of the country. Maharashtra is a major state where we see so many patients of tropical pancreatitis who have never touched alcohol in their lives. Even small children, young ladies, they come with dilated duct, radio-opaque stones. And one more thing I want to tell you is the pain in tropical pancreatitis is not like alcohol-induced pancreatitis. It is never so relentless. So if you do proper endotherapy and ductal clearance, majority of these patients have good pain relief and good life, quality of life.
Sir, I question. If a patient is having parenchymal calcification with duct stones, so endotherapy should be the first, or we should go for a surgery?
See, one more thing I'll tell you. Parenchymal calcification is a misnomer. Calcification cannot occur in the acini. The calcification is in the ductules, secondary and tertiary ductules, which are appearing like parenchymal calcification. You don't have to do anything for that. You remove and pulverize the stones from the main duct. Even if the main duct is clear, patient remains asymptomatic. Tiny calcifications in the secondary and tertiary ductules don't matter much.
Amit, brilliant and fascinating talk. Just one question. Any role for EHL or laser lithotripsy?
Yeah, I didn't show you that. But some stones which are refractory to ESWL, we do a pancreaticoscopy, and from inside we do a laser lithotripsy of the pancreatic stone.
So you mean to say EHL or laser can break more stubborn stones as compared to ESWL?
Yes, it can be, but ESWL is suitable for most. It works in most. And normal 20 watt holmium laser which we use for bile duct stones doesn't work for pancreas. So you have to use a high wattage laser, what they sometimes use in urology. So either that or we use a thulium laser.
Thank you. Thank you so much for being with us the entire morning.
Thank you.
It's
I'll have to
pleasure
make a move
listening
now
to you.
because I have to catch a flight.
Yeah.
Thank you.
So please give big hand to Dr. Amit Maydeo. Dr. Rupjyoti Talukdar had to rush for his flight. It's half an hour earlier than Amit's flight. So I thank the chairpersons, Dr. Upanshi, Dr. Amol Samarth and Dr. Dhananjay Kane for such a wonderful chairing of this session. Next talk is by Dr. Sadiq Sikora. We heard him during the panel discussion, what a brilliant academician he is, and the entire audience is eager to hear him straight talk. And the first, he will be giving back-to-back talks, and we do apologize to the intervening speaker, Dr. Vaibhav Manait, is consented to allow you 2 talks because you also have to catch a flight along with Dr. Maydeo. So your first talk will be of surgery in chronic pancreatitis, followed by the ABC of pancreatic cancer assessment. So may I invite the chairpersons for the first talk, surgery in chronic pancreatitis, Dr. Praveen Bhingare, Dr. Sunit Sood and Dr. Amol Dhoran.
As surgeons, we know that the patient will avoid his best to avoid surgery. And here we have had wonderful lectures by Amit sir about endotherapy. And surgery is, of course, the patient will come as a last resort after he has exhausted himself emotionally, psychologically and financially. So here we have Sadiq sir to present his lecture on surgery for chronic pancreatitis.
Thank you very much. It's always a pleasure to come to Nagpur, and I would like to thank the Vidarbha Association, Surgeons Association and DDS for inviting me. Isn't it always the case? The endoscopists do whatever they have to do, that they go home and leave the surgeon to do the work. So I think they have all left. Now we need to deal with...
But you can catch him on the flight.
So that's what. But I think after a long time I heard Amit give a view where he involved the surgeons having a role. So I'm glad. I think age is catching up with him. So, I mean, see, I'm going to be very simplistic because surgeons are very simplistic people. They know when to operate, what to do, and that's what I'm going to give. And since it's a mixed audience, I'm going to sort of introduce the non-surgeons to how we handle pancreas surgically with a video. So these are, everybody knows, these are the indications of surgery: intractable pain, complications, and suspicion of malignancy, which most endoscopic sessions don't talk about. And of course, that's one of the important considerations in chronic pancreatitis, it being a pre-malignant condition. What is important to understand is it's whatever treatment we do for chronic pancreatitis, it's palliative. And the goal of therapy is primarily to relieve pain or treat complications. By choosing a procedure which has low morbidity and mortality, and you expect that you would get long-term good functional results and quality of life. Now, the classical indications, as Rupjyoti showed, that classical indications of surgery are when you reach this area where severe intractable pain, complications, and subsequently it develops into cancer and things like that. And accordingly, the morphological changes occur. But now, as Amit also said, that there's more and more interest being generated in what is the good timing for surgery for chronic pancreatitis, or for that matter, any intervention. And early surgery now is being considered as something which has additional benefits, and we don't really wait till severe pain, intractable pain, and complications. And this one study highlights this fact. So about 260 patients, 5-year follow-up, pain relief 60%, which is actually real life. But when we look at multivariate analysis, what is important to note is good risk factors associated with pain relief are reported duration of pain less than 3 years, no opioid use, and less endoscopic treatments. And that also translates into overall better or lesser endocrine and exocrine insufficiency. So early surgery, as has been in this international consensus guidelines, it has been shown, and this is just amalgamation of all the literature which is available, that early surgery in the disease process achieve good long-term pain relief. The risk of developing exocrine insufficiency after early surgery is less. Long-term quality of life is good when surgery is performed less than 3 years. And as regards, there is some data which says that there may be a lesser odds ratio for developing cancer, but that's very iffy data. But there is something to suggest that cancer can be prevented by early surgery. So let's delve into what all surgical procedures we can do. So there is a huge spectrum of procedures, from pure drainage procedures in the duct with some of these names. Please excuse me as far as the medical gastroenterologists are concerned. So basically these are drainage procedures of the ducts, to hybrid procedures wherein you resect part of the head and then drain the pancreas, to finally resectional procedures like Whipple, pilus preserving pancreatic duodenectomy, and total pancreatectomy. So it's a spectrum of procedure. We get it from one to another. And the million-dollar question is, how do you choose which procedure to do? So again, as we discussed, and as Amit was also saying, that there are several considerations we have. Whether there is a head inflammatory mass, what is the morphology of the duct, multiple strictures, single stricture, the stones, how big, complications involving adjacent viscera like biliary obstruction or duodenal obstruction, and suspicion of malignancy as always to be considered. So I'll show some things, and in terms of, this is a large duct disease without head mass, and these could be treated either by endoscopy or surgery. But if you opt for surgery, then it is a good drainage procedure, opening the duct completely right up to the head and performing a pancreatic duodenostomy is a straightforward procedure which can be performed. If there is a duct, large duct with head mass, as we see in a good 30 to 70% of patients of various degree of head mass. Now in these, what are the options? So generally these are the hybrid procedures which we do, and our workhorse in India is a phrase procedure. Of course, when there is suspicion of malignancy, which are various criteria, clinical, laboratory, imaging, so on and so forth. If the suspicion is high, then we would prefer to do a resectional procedure. I was in a debate in Hyderabad regarding resection versus drainage, and there is a lot to talk about, and if the questions come, we can discuss that. So what is a phrase procedure? Again, just for, because it's a mixed audience. Basically, the key of phrase procedure is core out the head within the defined boundaries and provide a wide drainage of the pancreas. So if you look at this picture, the main duct is opened, this is the head, this is the duodenum, and this whole area has been cored out, and I'll show you a video of this procedure. How is it better than resectional procedure? Basically, it drains out the whole head, which is the pacemaker of the disease in chronic pancreatitis. Also, we preserve a lot of pancreas, which is what we need to do in this kind of disease. It can relieve biliary obstruction without concomitant biliary drainage. So it achieves all the goals of treating a head mass without resecting. There are situations when you have small duct disease with head mass. And in this situation, what are the options? You can do beggars, burns. I'll tell you what these procedures are, or a resectional procedure because there is a head mass in this, and if there is a suspicion of malignancy. So as far as beggars procedure is concerned, basically you excise the head up to this medial wall, preserving the capsule, and then do the anastomosis on both sides of the duct pancreas, which is preserved here, and the body and tail of the pancreas, drain it into the jejunum. A burn procedure is that you do a head coring, but don't transect the neck, but you don't open the main duct as we do. So it's a phrase procedure without opening the duct. And finally, you have a group of patients who have small disease, small duct disease, and these patients have severe pain. The cause of pain is multifactorial in this, but what surgical options do we have? We have a Isbicki procedure or a total pancreatectomy with islet autotransplantation. So this is the Isbicki procedure with a philosophy that you do a V-shaped cut on the pancreas, coring of the head, and drain this as a means of relieving the intraparenchymal hypertension in these patients. Total pancreatectomy is an extreme procedure over the spectrum of treatment as I showed you. It is with severe disease with persistent pain, small duct disease, which you think is not going to benefit by drainage, and usually it is in patients with hereditary pancreatitis. So the outcome is quite good actually in terms of pain relief and quality of life. What is good, especially when you do islet autotransplantation in this, is insulin independent in 1/3 of patients. And outcome is related to how much of islets you can give in this patient. But long-term results have been good with islet autotransplantation. Now there is lot of data and lot of literature available, and fortunately a lot of level 1 evidence in terms of randomized control trial comparing resectional procedures versus drainage procedures. Just to sort of summarize this, although these are small number patients, they compare resection versus drainage. The morbidity invariably is higher in pancreatic duodenectomy, and the quality of life is better with duodenum preserving head resections. These are some of the Indian series which we have published from Delhi, from Lucknow, from Lakeshore Hospital, Chennai, and Delhi again. Basically, good follow-up of 5 to 6 years of reasonable number of patients across the country with good pain relief. As a matter of fact, excellent pain relief up to more than 80%, suggesting that these are good selected patients which result in good long-term outcome. This is our experience over the last 13 odd years. Up to 2020, I've compiled about 150 patients. Most of them we perform a phrase procedure. Very small number of resectional procedures we have, and again on follow-up of more than 5 years we have a good 70% pain relief. So just to get the audience into this and see how we handle the pancreas, I'm going to show you a video of a phrase procedure. So this is a 26-year-old lady. Indication is a refractory pain. You can see large stones present in the head area. Duct is nicely dilated in this. So we do either a long midline incision or a Makuchi incision, have a good retraction. Now, to orient the non-surgeons, sorry. So this is the upper head end, this is the foot end, surgeon is standing on the right side, and basically the previous one you saw that the gastrocolic omentum is completely opened up, pancreas is exposed. Now what I'm trying to show you, sorry. So basically duodenum should be well cauterized, and that's the key step because we want to hold the pancreas in our head. Once we have done that part, we have full control of the pancreas. Then we take the vessels around. The second important step is that we need to deliver the pancreas out from the retroperitoneum. That means the inferior border of the pancreas is mobilized, the superior border is nicely mobilized, so that the pancreas is delivered out. And once that is done, you would be able to open the duct and do the anastomosis well. The right gastroepiploic vessels are taken so as to expose the area of the head of the pancreas. Now the identification of duct by needle insertion, once you hit the duct, you will see the pancreatic juice being aspirated. Then I keep the needle at that point and then with a sharp cautery incise till we reach the needle and have a gush of pancreatic juice. Once you have that, and then you start opening the duct primarily towards the tail region. You may get some bleeding in this, control it with sutures or bipolar cautery. Now this duct opening should be, since we have mobilized it completely, based on the morphology, right up to the tail, the duct is opened up and all stones are removed. Now you will see in the video that some of the stones, a question was asked about stones in the side branches. So here you see the stones in the side branches. And the best instrument to remove these stones is your flat end of the cautery, because these are spiculated stones, and if you try to hold and bring it out, it will break. So use the flat end of the cautery to get into the duct around the stone and deliver these stones rather than extract them. Now the key part of the surgery is the head part, because head has to be addressed well. Failures of surgical procedures are primarily due to inadequate treatment of the head. So now you see that we know where the duct is, and you start incising on the duct and you start delivering the stones which are present. Again, the boundaries has to be defined, that how much coring you are going to do. So medially about 1 centimeter from the margin of the duodenum. Also, as I showed earlier, the superior mesenteric vein, and I'll show you again during the part of this video. So you keep on opening the duct, and all these are the sentinel stones right at the mouth of the ampulla, and you open up the ampulla completely. So this is the medial border of the duodenum. You keep about 1 centimeter or so as to take the sutures, and then you start now coring the head. And coring has to be done in slices so that you can make sure that you don't end up with a lot of bleeding, and you don't unnecessarily remove pancreas which need not be removed. One of the things, as I showed in the beginning, is the good cauterization, so that when you hold, if there is a bleeding, you can always control it, and then of course put sutures or bipolar which is required. So as you can see, again we are removing all these stones which are present near the ampulla, so that the blockage is relieved. Now this is the superior mesenteric vein. Can you see here? I think this is given up. So this is the superior mesenteric vein, and again you decide, once you identify that, you start coring from medial aspect. So I just wanted to show this head coring because I think head coring in pancreas is very critical. And now you can see that sliver of tissues we are taking one by one so that adequate drainage is achieved. So you keep on going, and finally you open up the uncinate ducts, all the side branches, all these stones. Again you see that in the uncinate duct these stones are present, and eventually all stone load is removed. There you are now entering the ampulla and into the duodenum. Once we make sure that all the sentinel node has been removed, stone has been removed, you can cannulate that. Now let me come to the anastomosis. So this is the complete dissection after coring, and then finally we do the pancreaticojejunostomy. Let me just rush through this since it's not a surgical audience. So again, we place sutures. I do a single layer anastomosis, but you see how when the pancreas is nicely mobilized, you can do this. This is a anchoring suture so that the loop sits there. And eventually, we will do an enterotomy. And I use a double arm proline 4-0 suture and run this anterior and posterior, the corner one being a cornel stitch. So while this is being done, I'm done with my presentation of chronic pancreatitis. This can run, and in case there are any questions, we can address that in surgical treatment of chronic pancreatitis while this video is running.
Sir, may I ask you one question? Do you do it laparoscopically?
We have started doing laparoscopically. See, one of the things my concern has been that unless you do a good head coring, it is not a good operation that you do. And one of the problems which I always used to face is that we can't get our hand, which is I feel is very critical one, in order to do a head coring. But I think now with our increased ability to do procedures laparoscopically, and more so because now we have started doing robotic surgery, I feel more comfortable doing a head coring by robotic rather than by laparoscopic.
So another question, do you protect CBD by doing preoperative ARCP and stenting?
Do I?
Protect CBD?
No, actually, you don't need to preoperatively protect the bile duct. You know where the bile duct is. Technically, basically, when you follow the duct, you know it is medial and on that quadrant on the left side of the duct. So you avoid deep coring on that side of the duct, and rest of the coring you perform on this side. So there is no need for protective stenting. Inadvertently, if a bile duct is opened, which may happen very rarely, if it happens and if the duct is good size, you just close it. If not, you just open it into that cavity because you are going to do a pancreaticojejunostomy anyway.
What do you prefer if there is a CBD stricture?
If there is a stricture, there is a whole different algorithm to treatment.
Okay.
You want to know what is the type of stricture, whether it is a long stricture or a short stricture or a lower end stricture. Sometimes it is just because of head mass. So what we would do is we would do a head coring, do a cholangiogram. If there is adequate drainage, I would leave it at that. If there is a tight stricture which is not opened after a coring, then I would do a drainage procedure. If in the beginning there is a suspicion that this is a iffy situation in terms of the head mass being malignant, and that is why there is biliary obstruction, I would choose to do a resection in that.
Okay. One more thing. Any tip on finding out the pancreatic duct? Sometimes it becomes very difficult to find out pancreatic duct.
Yes. So again, studying preoperatively the morphology is very important. You would know how the duct is dilated, what is the status of the duct from the surface of the gland. We do those measurements so that we get an idea. But sometimes, yes, if the duct is less than 6 millimeter, which is sometimes happens, it is difficult to identify. So what I do again is first start off with needle, putting in a needle. If there is a stone which is in the body and tail of the duct, I sound the stone and open on the stone and then get into the duct. Sometimes I make a oblique opening onto the parenchyma of the duct in the body so that I can hit the duct. If these things fail, we do have intraoperative ultrasound. I use an intraoperative ultrasound. Sometimes what I have done is I have started coring the head first, and then I identify the duct there and then trace the duct back. So you will have to adopt various means of doing and identifying the duct.
Can we just cut the tail and follow the duct from behind?
Sorry?
Can we just cut the tail?
Tail. Yeah, that is that classic, lateral pancreatic or jejunostomy or Pusto's procedure, which was classically described, which had you cut the tail, identify the duct and all. But now, I think with all the things available with us, we don't need to do that. And if you need to do that, you will have to also dissect off the vein and all, and then do the transection. So it may get a little messy.
So we have a question from audience, I guess. Someone, yeah.
Sorry.
There are tail towards the tail. There are stones towards the tail of pancreas. That's what.
Yes. Yes. So again, once you study the preoperative imaging and you know that there are stones there, you need to ensure that all those are removed. So that means you have to do a stone mapping, and then based on where the last stone is, you need to open up the duct right up to there. That's why you need to mobilize completely, open the gastrohepatic omentum, lesser sac, and expose right up to the tail.
Sir, I have last question. So the extent of coring, there is always there is north-south divide, and that, like H. Ramesh sir goes up to the posterior pancreatic capsule while doing the coring, and we at AIG used to do just up to the duct. The anterior part of duct used to core. What's your take on that? How much coring we should?
See, the basic premise of coring, my philosophy is that you should have a good drainage of the head. So that's the philosophy. Now, the duct posteriorly, it depends. Sometimes what happens, because of the mass being there, you don't have a properly defined duct. In that situation, you have to keep on coring till you remove all the inflammatory mass. And there, the sort of guidance is that you reach up to the posterior capsule. But if there is a dilated duct, or if the duct is identifiable, I think keeping up to the duct posteriorly is good enough. But from there, you should also open up the uncinate ducts, because just reaching the duct is not enough. So you will have uncinate ducts which will be running inferiorly, and those through the opening you should open, and that coring of the uncinate should also be adequate. So my margins are about a centimeter from the medial margin of the duodenum, posterior the duct, uncinate process nicely sort of opened up, and medially about a centimeter from the superior mesenteric vein. And this whole thing, once you lay it open, it should be adequate.
Thank you, sir. I thank chairpersons Dr. Amol Doran, Dr. Praveen Bhingare, and Dr. Sunit Sood, sir. I now invite next chairpersons, Dr. Abhay Chowdhury, Dr. Raju Wilkinson, sir, and Dr. Abhinav Deshpande to chair the session on ABC of pancreatic cancer assessment.
Yes, indeed. Thank you, Dr. Sadiq Sikora, for that simple, brilliant, and very convincing videos of surgical techniques in chronic pancreatitis, and a lesson and a very important thing for us endoscopists to see all these videos. So we are heading towards the last module, which is pancreatic malignancy. And as I had said before, with due apologies, we're putting the cart before the horse. So the first talk, etiology and risk factors of pancreatic cancer, will be taken up after your talk. And you will be speaking on ABC of pancreatic cancer assessment. Over to the chairpersons.
With no further ado.
Shall I? Okay. Okay. Thank you very much, and thank you for the speaker to concede, to let me finish. Now, this is again going to be a very simple and straightforward. I don't think there is any great sort of pearls which I'm going to give in this, but I'm just going to make a comprehensive thought process toward assessment of pancreatic cancer. And again, since both medical gastroenterologists and surgeons see this disease, I think it is important to understand that what are the considerations in assessing this these patients, so as to have a treatment strategy clear for that. So I'm just going to restrict myself to assessment of these patients. And generally, the best thing to assess all of these patients of GI malignancy is the acronym ABC. So why we need to have a good assessment? So the single most important goal is to achieve an R0 resection, because that translates into outcome in our patients. And unfortunately, in pancreatic cancer, there is a very high rate of R1 resections. The reason being of the complex sort of location of the tumor and the relationship to other vascular structures, which result in R1 resection. And therefore, it becomes all the more important to categorize them into areas like resectable, borderline resectable, and unresectable, so as to determine what is the best strategy for that. So as I said, the acronym ABC, which is anatomy, biology, and condition of the patient, should be the cornerstone of assessment of all patients with cancers. So let's see what the anatomy has in store as far as pancreatic cancer is concerned. So the workhorse of anatomy is imaging. And imaging is a cross-sectional imaging, which a preferred one is a contrast-enhanced CT scan. And what information we need in this? Basically, we are looking at from top down whether it is a metastatic disease. Once we cut that out, what we are looking at, is it resectable? And is there any vascular involvement? And if there is vascular involvement, is it borderline resectable, or it can still be resected? Another important thing, I think, for surgeons, it is very critical to remember that vascular anatomy, abnormal or deviations of anatomy are more common than one is thought, or one thinks that it is like that. And it has bearing on the surgical procedure. And it is always very important to look at the imaging from the point of view of replaced hepatic artery, common hepatic artery coming off the SMA, and these, because these are bearing on the surgical techniques. Also, now we know a lot of risk factors which are available for predicting pancreatic fistula. And the two common ones are the amount of fibrosis or fatty content of the gland and the duct size, which can be obtained by imaging preoperatively. So you can see that there is a lot of information based on how you look at the imaging, so as to have a strategy and prognosticate. Also in the anatomy, it is important to, the vascular involvement is very critical. So venous anatomy involvement by MDCT, MRI, and endosono, and these are the sensitivity and positive predictive value of these. So based on the imaging that you do, you identify or define patients into resectable, borderline resectable, and unresectable. So what is resectable? So this is the MD Anderson criteria: no extension to SMA, no extension to celiac, and the SMV portal vein is patent, and of course there is no metastatic disease. So if you look at a CT scan of this is the tumor. You can see the planes with SMV and SMV very clear. And this patient, basically when you look at from ABC point of view, would be no vascular involvement, no distant mets on CT, PET is optional, CA99 is low. Usually the cutoff for saying borderline is 500, so it's less than that, and the patient is ECOG 0 or 1. And this is a resectable pancreatic cancer. Upfront surgery would be offered to these patients. So the next step is borderline resectable, and again borderline resectable can be anatomical, biochemical and conditional. So let's go to conditional first, that there are certain situations which can be improved, say comorbidities, pulmonary comorbidities, a cardiac comorbidity, and this can be improved. So the patient is borderline resectable, can be improved to make it resectable. Similarly, biology, that if there is a very high CA19-9, more than 500, it indicates that this is an aggressive disease. If there is lymph node positivity, it indicates aggressive disease. So this is borderline resectable biological. And anatomical borderline resectable, again there are various definitions of this. Basically, without getting confused by all this, there are various societies which have defined that. But what you need to understand is that the SMV portal vein is one, and if there is involvement of more than 180 degree or there is occlusion with reconstruction being possible, that is borderline resectable. If for SMA there is 180 degree abutment, it is borderline resectable. And with common hepatic artery, there is short segment involvement or 180 degree abutment, it is borderline resectable. So just keep that 180 degree for arteries and more than 180 for veins, which can be resected, and that you would get a definition of borderline resectable cancers. Vascular involvement, again there are various criteria which are used. So basically you are looking at fat planes around that. If those are lost, then there is irregularity of vessels, less than 180 abutment, or there is encasement or occlusion and eccentric narrowing. Those are type D and 4. So we'll see some examples of this. So you can see here, there's a tumor here in the pancreas. The SMV you can see is irregular, loss of fat planes, and this is type C involvement of the SMV, which would need resection, or it's a borderline resectable if you want to go ahead with neoadjuvant chemotherapy. Again, you can see loss of fat planes, irregularity, teared up deformity, and partial occlusion. And this is what you get on operative impression. So you can see this is the tumor and this is the involvement of the vein, and you have various options, either resect or do a sleeve resection of the vein in this scenario. Or this is another mucinous tumor with vein involvement wherein vein resection was done. So pre-operatively knowing whether vein involvement is present, you determine the strategy, either neoadjuvant therapy or resection. So again, there is some videos of SMV abutment which you can see. Can follow the SMV and you will see that duct is dilated, and then you can see more than 180 degree abutment of this. When you come to SMA, again follow the SMA coming off. This is the celiac, this is the SMA which comes off, and then you follow this and you see tumor around the SMA about 180 degree in this area. So this becomes borderline resectable. Now I mentioned about abnormal anatomy, and in this series of x-rays you will follow the SMA. The replaced right hepatic artery is arising, there it is arising and going through the tumor, and this is a critical situation wherein it is a replaced right hepatic artery going through tumor which would need a reconstruction. This is another interesting case which we encountered. This is the common hepatic artery. There is no hepatic artery from the celiac, common hepatic artery arising from the SMA, and there is a neuroendocrine tumor, and this common hepatic artery is coursing through the pancreas. Since it was a neuroendocrine tumor, we did a modified kind of Whipple resection, preserving a lot of pancreas and the vessel which was running inside the pancreas. So now you understand that vascular assessment is important. It becomes borderline resectable. If the vein can be resected upfront, many people may choose to resect that, but more often than not, now it is being believed that you should do a neoadjuvant therapy for this. But you have these kind of scenarios also where artery is completely encased, vein is encased, and this is a much bad scenario which is unresectable, or you can have this encasement of celiac and SMA wherein it is an unresectable tumor and you may do a palliative chemotherapy for this. And of course finally you get metastatic disease, like in this situation it's a neuroendocrine tumor with a hypervascular metastasis. So biology, as I said, that you need to pay attention to CA19-9, but it has various connotations in pancreatic cancer. It may be raised in presence of jaundice, in cholangitis, so the cutoff value becomes important. After drainage, if it remains high, it is of significance, and if this is very high, as I said, more than 500, then it is to be considered as suggestive of aggressive biology of this patients. And why it is important is, if you look at this analysis, and what I just want you to understand from this is, amongst the various factors which determine the outcome, that is margin, neoadjuvant or adjuvant therapy to be provided, CA19-9 is the only preoperative sort of evaluation which gives an idea about the aggressive nature of this disease. So CA19-9 is important. And finally, the condition of the patient. Now we know that associated comorbidities have a bearing on tolerating chemotherapy, on tolerating surgery and outcome from surgery. Obesity is directly a risk factor in terms of leaks in pancreatic anastomosis, and of course ECOG status determines how well the patient can tolerate either a neoadjuvant strategy or a surgery in these patients. So finally, to summarize, I think preoperative assessment is essential because it tells you resectability, biology of the disease, fitness of the patient. It helps you plan the treatment strategy, technical issues and challenges during surgery, and also prognosticating, because you can tell the patient that this is a soft pancreas, it's a small duct, the risk of leak is very high by all criteria, and you need to be prepared for that. CECT, of course, is a workhorse of this assessment, and as I said, that based on this, you can plan the surgery preoperatively, and better prepared is better outcome. Thank you very much.
Thank you, sir, for such a lucid description of ABC of pancreatic cancers. Sir, I would like to ask, when would you consider diagnostic laparoscopy in cases of pancreatic cancers, as well as the other imaging modalities like endoscopic ultrasound or PET scan?
Yeah, so I mean, excellent question. So diagnostic laparoscopy is, if I'm operating on any patient with pancreatic cancer, they would have a diagnostic laparoscopy, because about 20 to 25% would have metastasis which has not been picked up. So in pancreatic cancer, definitely as a before surgery. Now there is a debate regarding neoadjuvant therapy, that whether all patients who are fit to undergo neoadjuvant therapy should have a preoperative diagnostic laparoscopy. And I am in favor of that, that if we are subjecting these patients, so we would do a stenting, we would have a histology, and these patients, while their bilirubin is coming down, they would undergo a short anesthesia and a diagnostic laparoscopy prior to a neoadjuvant therapy. As far as EUS is concerned, any mass, because when they need a preoperative or neoadjuvant therapy, you need a histological diagnosis. And therefore, most of the patients with pancreatic cancer would require a EUS and a biopsy in this. Also, in the current scenario, resection or doing a Whipple procedure, it probably is worthwhile always offering one attempt to establish a histological diagnosis, even if you're doing an upfront surgery, especially with the advent of EUS. So it would be part of my preoperative workup of all patients with pancreatic cancer prior to surgery. The final question is about PET CT scan. And PET CT scan is not mandatory in all patients of pancreatic cancer, but those undergoing neoadjuvant therapy, those having high CA19-9 would undergo a PET CT to rule out metastatic disease.
Any more questions?
Thank you, Dr.
Hi,
Sadiq.
thank you very much.
It's,
Thank you very much.
Not difficult to see why you are so popular here, and it's been pleasure and honor to have you for this entire session. And it was simply brilliant and very insightful, not only for surgeons but even for gastrophysicians equally. So thank you very much. Please give a big hand to Dr. Sadiq, because he's also leaving his got a flight to catch. Thank you, sir. The next speaker who would have been the first in this session is Dr. Vaibhav Banait. He'll be speaking on etiology and risk factors for pancreatic cancer, and the chairpersons are Dr. B.S. Gedam, Dr. Siddharth Dubashi, Dr. Manoj Vyavare, and may I request Dr. Vijay Kavalkar also to join in if he's there. Dr. Amol Deshpande, are you here? Can you please join the other chairpersons? Sorry for the last minute request.
Well, we have heard about the chronic pancreatitis and its management, and chronic pancreatitis itself remains one of the important etiological factors for malignancy. And the factors which cause chronic pancreatitis can also be the etiological factors for the pancreatic malignancy. So, to add further information on this, I think we switch out to the speaker about the etiology and the risk factors for pancreatic cancer. Dr. Banait, please.
Good afternoon. You have already done ABC of a CA pancreas. The CA pancreas has been diagnosed and staged. Now patient asks you 3 questions. The first one, why me? Am I the only person to suffer from this disease? 2, what will happen to me? 3, what will be the next thing? So trying to answer first few questions. As you know, pancreatic cancer, as we are referring here, is adenocarcinoma arising from the epithelium of the duct. It is very serious cancer, lethal cancer, almost accounting for the, it is 7th leading cause of death all across the world, and 4th in Europe and Western countries. In India, it is uncommon. It accounts for around 1%, 1 per million. The incidence is around 1 per million, while the incidence goes as high as 10 per million in Saudi Arabia and Europe. If you look at this graph indicates the diagnosis, incidence versus the mortality, and it is running very close. The ratio of incidence to mortality is 1. That means that those who are diagnosed are destined to die. It is like a death sentence given to this person. So it is lethal, deadly cancer. Why so? Because it is diagnosed late. This is almost 25 years data that shows that This is stage 1, this is stage 2, this is stage 3 and stage 4. So most of the cancer, CA pancreas, are diagnosed late in stage 2, stage 3 and stage 4 stages. This has not changed over many years in spite of phenomenal diagnostic modalities and technological advances. And thus it is not surprise that this disease is becoming a deadly disease. But what happens to those who are diagnosed very early in this stage with endosonography and other high-end modalities and are young? This graph indicates the mortality at various ages in a stage 1 and 2 of CA pancreas. The blue is, this indicates the mortality in the age group of 20 to 40, while this indicates mortality in a higher age group. And you can see that only around, even in a young patient, young robust patient, the survival of 1 year survival is around 30%. And what happens to the advanced stages? The mortality is very high. Very few are surviving a year. So this is lethal disease. Most of the patient will die before they celebrate their next birthday. So interpretation of this data is CA pancreas is a grave disease. It is difficult to diagnose. Why difficult to diagnose? Because most of the early presentations are subtle. They will present with belching, bloating, loss of appetite. There is no definite localizing symptoms. Jaundice and new onset diabetes is a rare presentation or late presentation. It is also considered as a graveyard for radiologist or sonologist. So CA pancreas is not very easy to diagnose on ultrasonography. So, and there is no effective chemotherapy or surgery. So whatever my surgeons and oncologist friends say, does that mean they are not working? It's not so. The 5-year mortality is only 6% before the advances, and it has now 5-year survival is only 6% before the chemotherapy and surgical treatment has advanced, and now it has increased to 9%. So there is slight little bit of improvement in the survival with advances in technology. The next question was, why me? So let us try to have what are the risk factors for CA pancreas. There are two risk factors, modifiable and non-modifiable. Non-modifiable are age, gender and genetic factors, and modifiable are smoking, alcohol consumption and chronic pancreatitis and diabetes. CA pancreas is a disease of elderly. You will hardly see any patient younger than 40 developing CA pancreas. As the age advances, the incidence of CA pancreas increases. There is not much difference between males and females. Family history, a study from Delhi had shown that the CA pancreas is more common in patients who have family history of CA pancreas, almost 3 times higher than the those who do not have CA pancreas as a family history. First degree relative, multiple relative, if the person is having, they are more likely to develop CA pancreas. As a gastroenterologist, I am often focused on alcohol. I keep asking about alcohol because that is bread and butter for most of the gastroenterologists, alcoholic liver disease, alcoholic chronic pancreatitis. But, and we tend to forget about asking about smoking. We literally never ask because it is work of a pulmonologist. But the studies have found that smoking is a greater risk factor for CA pancreas than the alcohol. It accounts for almost 25% of all pancreatic cancer cases. And not only this, smoking decreases the duration between development of chronic pancreatitis and development of cancer. So it is important to note the history of smoking and ask the patient to stop smoking. These graphs show that the intensity of smoking, duration of smoking and cumulative amount of smoking all increases the risk of CA pancreas. And the fourth graph here suggests that even if the person stops smoking, the decrease in the risk is very gradual and very gradual. But nevertheless, one should ask them to stop smoking. Obesity is risk factor for many other cancers also, and it also increases the risk of CA pancreas. And the risk is highest in those with BMI greater than 35. And chronic pancreatitis, diabetes, and CA pancreas go hand in hand. Many of the diabetic patients later on develop pancreatic CA, and it is the incidence, the risk is almost 2 times higher than the non-diabetic person. It is more in long-standing and poorly controlled diabetes. So there are a lot many presentation on chronic pancreatitis developing CA pancreas, how to identify CA pancreas in a setting of chronic pancreatitis, whether there is whether the head mass is CA pancreas or chronic pancreatitis. There is good study by Ramesh et al. Who found that the chronic pancreatitis is a risk factor for CA pancreas. It increases the risk of CA pancreas by 2.9 times. And risk is higher in those with hereditary and idiopathic chronic pancreatitis. This is the graph showing the duration of duration of chronic pancreatitis and the incidence of CA pancreas. Of course, as with all other cancers, genes play a good role in development of CA pancreas. These are various genes that have been identified. BRCA1, BRCA2, ATM and Lynch syndrome, they are associated with the increased risk of carcinoma pancreas. In conclusion, prevention of, because you cannot treat CA pancreas, by and large, most of your chemotherapeutic agents and surgical techniques have failed to improve the survival. Prevention of pancreatic cancer is critical, and as it is often diagnosed late, has poor prognosis, you should ask your patient to quit smoking, or best never to start. Maintain healthy diet through healthy weight through diet and exercise. Control diabetes through medication, diet and exercise. If they are having chronic pancreatitis, manage the chronic pancreatitis with appropriate medicine and limit alcohol consumption. Thank you.
Thank you, Dr. Knight, for your presentation. You did highlight few studies from the Indian literature pertinent to smoking and history of pancreatitis. Are there any studies which have identified specific risk factors for the Indian subset population?
These are all the risk factors, not particularly in Indian context, but all across the world. Which
that's what the question is, that are there any studies which have highlighted any